Doug Carr, I think you're on the line, our co-chair, or vice chair. Oh, there's Jeannie. Hi, Jeannie. Are you on?
Yes, ma'am, I'm here.
Great. I'm just going to do another quick check. Bill, are you on the line, Bill Osborne?
Yes, I am here.
I think welcome. Dolly, are you on the line?
Good morning, this is Dolly.
Hi, Dolly. Thank you. Okay, I'm going to go ahead and get going here pretty shortly. Thank you. This is Lisa Bowie with the OHA Quality and Health Outcomes Committee, otherwise known as QHOC. We are going to go ahead and get right started. I'm going to just do a quick overview so we can switch right over to the Oregon State Hospital. Just as a reminder, please remain muted when not speaking. This is a Zoom line, so if you are having difficulties on your phone, please use *6 to try and mute and unmute your line. When possible, use the reactions button and raise your hand, and we can call on you when you have questions. You can also use the chat function. And if you are speaking, it'd be great if you'd like to please turn on your camera and as well announce who you are and the organization you're speaking from, and then feel free to ask your question. We are glad to start off this meeting with the Oregon State Hospital conversation. I know the medical director specifically and others have been requesting this conversation, and we are happy to have Dolly and Bill from our Oregon State Hospital leadership team, and I will honestly just go ahead and turn it over to them. Jennifer, if you want to go ahead and just advance a couple of slides, that'd be fine. The Oregon State Hospital one. And then Dolly, if you would want to just introduce yourselves and the participants that you've brought to the conversation, then please do so, and you've got the floor.
Good morning, and thank you very much, Lisa, for that introduction. My name is Dolly Matucci. I am the superintendent at Oregon State Hospital. Also with me this morning is Dr. Sarah Walker. She is our chief medical officer. And then, as you had introduced, Lisa, William Osborne, Bill Osborne is here from OHA as it relates to OSH capacity and the capacity across the behavioral health continuum of care. So as it relates to an update at Oregon State Hospital, as you all know, our patient population has shifted dramatically since 2012 with an ongoing increase in demand for services for individuals under aid and assist orders. And that part of that demand requires Oregon State Hospital to admit individuals under aid and assist orders within 7 days of receiving a signed order. That is the MINC injunction that we have been under for a number of years now. Prior to 2012, we have consistently been able to meet that requirement. And since that time, with the steady increase as well as some unprecedented spikes in a number of orders received, we have not been successful. So we have been in and out of court proceedings related to that requirement. And most recently, we have entered into an interim settlement agreement with Disability Rights Oregon and Metropolitan Public Defenders, where we are now working in cooperation with a neutral court expert to assist both OSH in meeting its demand for services for individuals under aid and assist orders, as well as building the continuum of care so that individuals receive the right level of care at the right time in the right place, both pre-OSH service need as well as post-OSH service need. And part of that interim settlement agreement looks at OSH developing a standardized admission protocol that, as well as discharge that leverages best practices, and that seeks to get individuals under not only aid and assist orders, but GEI orders in within more reasonable timelines and more consistent across the wait lists for those individuals. OSH received $31 million from the legislature to open the 2 additional units on the Junction City campus that were previously not open for service. They are at an SRTF level of care. They have been opened on the Junction City campus. The first unit, providing an additional 24 beds, opened in November of 2021, and the following and last unit available opened in February of 2022. As it relates to our cross-campus capacity, that would be Salem campus as well as Junction City, we are at maximum capacity now in terms of our real estate and active bed availability. All of that said, we are continuing to admit individuals as timely as we can, as bed availability allows, acknowledging we have had some pauses in admissions during the pandemic. And we are working to kind of catch up following those pauses in admission, and we are doing so with heavy admissions this month. Recognizing all of that work, the bed capacity does continue to be consumed primarily to provide services for individuals under aid and assist orders, as well as those deemed guilty except for insanity, providing very little opportunity for OSH to provide services to individuals under civil commitments. And we at both OSH and OHA recognize the impact that that has on our community partners that are providing services to individuals that can be served on occasion by Oregon State Hospital. In January of 2021, we developed an expedited admission criteria to serve those individuals that are providing the greatest degree of complexity and challenges to our individuals across the continuum of care, providing services to civil commitments in acute care facilities. And since having done that in January of 2021, we admitted 4 individuals under our expedited admission criteria and 3 thus far in 2022. And we realized that those individual cases and the admission is helpful, that there is still tremendous pressure for those providing services to individuals under civil admissions, for which there has been a referral to OSH and for which individuals have been placed on our admission list. At this time, I would like to introduce Dr. Sarah Walker so that she could provide some information on our expedited admission process. Dr. Walker?
Hi, everybody. We do have an expedited admission process for both our forensic population and our civil population. The link to the document itself is on our website, the legal affairs section of the OSH part of the OHA website specifically. And the link is there to both the civil and the forensic criteria. The civil commit patient criteria is looking really at 2 factors. One is this person, somebody who we've already identified as meeting criteria for OSH admission, and somebody we've already got on our admission list. And number 2, are they engaging in the kind of violent behavior in particular, but in terms of severity and frequency, which is really not safely manageable in a community acute care health setting. We recognize that these are folks who almost without exception are already in acute psychiatric care, and that we trust that, as with any other acute inpatient psychiatric setting, they can safely manage suicidal behavior. They can safely manage severe persistent mental illness symptoms. And we also know that the OSH physical plant and staffing and training tends to be better suited to working with the folks who are at very high risk and are engaging in severely aggressive behavior. So there are 4 criteria that all of which have to be met, having to do with aggression, need for seclusion and restraint, ongoing risk that is unmanageable in the acute care hospital setting. We do get referrals from acute care hospitals, and in many of those cases, those are folks who we agree meet the criteria, and we've brought them through the door. In many of those cases, the folks that we've brought in have also required significant seclusion restraint in our own facility before they stabilize. So we definitely agree with the referring hospitals that those are folks who are more appropriate for our setting, and we appreciate the communication. What really helps is when we get good comprehensive records to support the request. So generally speaking, I'm the one, or the chief of psychiatry are the ones who review the requests, and we typically try to get back to folks pretty quickly, usually within about 24 hours. Dolly, was there anything else that you were looking for?
No, Dr. Walker, thank you. That was it in terms of the process. Lisa, I'm not able to see participants or chat, so are there
Yeah, I think
questions or
now would be a good
comments?
time. If you have, so thank you again, Dolly and Dr. Walker for just creating the time and space for this. And thank you to Dr. Dawn Montner for continuing to facilitate those connection points to bring you to this meeting. Now is the time. So for CCOs that are on the call, we have at least 3 individuals who are connected into the state hospital work, and obviously Dolly as the administrator. If you want to put in your chat string, raise your little hand in the reactions box, turn on your camera and physically raise your hand. I'm happy to start to facilitate some conversations and discussions. No need to be shy. And then Dolly, I'll just kind of call on the individuals or the chats as I see them pop in.
Thank you.
Thank you, Dolly, and thank you to Dr. Walker, and thank you for coming today to help us understand. My name is Dawn Moutner, she, her, Aya, white woman, long brown hair, Medicaid medical director for OHA, and I appreciate your responsiveness and your acknowledgement of the ways that the capacity issues are potentially impacting our communities, and so the people on this call whose concerns I'd like to invite to the open air are the Medicaid medical directors from the CCOs who have been working to facilitate transitions of care into higher levels of care and struggling to find behavioral health capacity sort of across the state at varying levels of acuity, and also for a variety of populations, from kids to adults, and particularly under the additional strains that COVID has put both on the communities and on the infrastructure and workforce of behavioral health beyond the walls of the hospital. May I ask you to speak to those a little?
Thank you. So, I will ask Bill, I will kick it off, Bill, and then if you want to jump in terms of the efforts that OHA has taken to build capacity across the continuum in terms of different levels of care. The focus for OSH, of course, is always hospital level of care, and that is the level of service that we provide in addition to some SRTF capacity. And I think Bill can best speak to the additional efforts that are taken to provide capacity and support across the continuum. I think he might be best able to provide that additional information.
Great. Thanks, Dolly. I can just give a brief update on some of the work that we're doing. So we do understand that relieving some of the pressure to the state hospital has been really, really the focus of the work of my team. I manage the intensive services team, and we've been looking at the continuum of care, not only for folks that are under aid and assist, but also for the civil population and for the GEI population. So the main thing that happened was the legislature approved about $130 million in housing funding. An RFP went out late last year, and has just now, and is going out in 3 parts. So the first part was really targeting 3 priority populations. Those were folks under aid and assist, civil, and PSRB, the GEI population. And so the first phase of that is now currently being scored. And so the hope will be that they will add additional capacity for beds in the community for those populations, hopefully within the next 6 to 12 weeks. That was the first push. The second part of that RFP process will come out, and that process is really more for the sticks and bricks facilities. And so folks will be able to apply for funds and hopefully get funds and get those other services up and running. And then the third and final phase will be for other levels of residential care throughout the behavioral health continuum. The other thing that we've been doing on my team is we've been looking very, very closely at those folks who are at Oregon State Hospital who are ready to place. And we are then connecting with communities to try to figure out what the barriers are to their placement to the communities, with the hope that, if we can relieve some of the pressure on OSH for our aid and assist folks, that will then free up some capacity for our civil folks, and then we'll hopefully relieve some of the pressure that acute care facilities are having in the communities. And so we are looking at that list regularly. We are working to engage CCOs in helping us with some of that discharge planning and some of that engagement, locating resources for folks. We are starting a pilot project in Multnomah County where we're looking at folks that are currently in custody and are waiting to go to the state hospital to see if we can have any impact on moving those folks out of custody and into the community rather than sending them to the state hospital. PSRB is the Psychiatric Security Review Board. There was a question in the chat. And GEI is folks that are found guilty except for insanity. So those would be our 3 kind of court mandated populations are our GEI populations, our civil populations, and our aid and assist population. The other thing that we are doing, there is hopefully going to be a 16-bed SRTF that will open on the Junction City campus. At this point, they are estimating that's going to be in May or June, but obviously due to some workforce issues, we're all trying to struggle through those. And my hope is that they'll be open by then, but it may be pushed out a little bit because of workforce issues. And then we're also talking to some providers locally who have some bed capacity to see if we can locate any other bed capacity in the community, again, to really relieve the pressure at Oregon State Hospital. So that's a very, very quick rundown, but I don't know if folks have questions. I would be happy to answer them.
Thanks, Bill. We have a few questions. We're going to go to Deanne first, and then we're going to go to Jeremy Kohler from Health Share. So Deanne, you've got the floor, and then we'll see if it's more appropriate for Bill, Sarah, or Dolly. So ask your question, and then I'll throw someone under.
Wonderful. Well, good morning. My name is Deanne Carr, I'm Behavioral Health Director with the Yamhill CCO. And I guess my question is more around just the future vision for the Oregon State Hospital. I both acknowledge that there's been a lot of challenges, and COVID has certainly exacerbated those challenges. So I want to be respectful of that, but simultaneously, the civil commitment population, speaking of being thrown under the bus, and not in a intentional way, but just in a systemic way, that this population really has suffered from this lack of access. And so I do have curiosities just overall. What's the plan for returning access to a clinically indicated level? Because I do think that while there are the RFPs coming out and funding for secure residential treatment facilities and things like that, there's a ripple effect. Well, There is a challenge with SRTFs in that they vary as to the level of acuity of individuals that they will take and circumstances under which they ask people to leave that setting. And so I think that we need to acknowledge that while certainly helpful, once that gets up and going and that increased capacity exists, it's not going to supplant the need for a certain level of capacity at the state hospital for, shall we say, our more complex and perhaps more volatile civil commitment population. So I'm just sort of curious, that larger overarching, and probably one side comment more than a question is, I think that there is going to need to be some discussion around oversight of SRTFs on the part of OHA and the ability to monitor to ensure that the SRTFs are taking individuals that are actually at the acuity that they are attended to, and that we avoid what the system refers to as cherry picking. Thank you so much.
Thank you, Dolly. It looks like you've got that one.
Yeah, I raised my hand to take the first portion. So it truly is, with OSH having maximized our available bed capacity, it truly is the building of the continuum across all commitment types, right? So to be able to have diversion for individuals that don't need hospital level of care, as well as timely discharge options when they're no longer needing OSH hospital level of care, so that we can have beds available not only for individuals under aid and assist orders, but those under guilty except for insanity, as well as civil commitments, so that we do have more bed availability for timely admission to individuals requiring civil services, as that shift has been dramatic and difficult for all across the continuum. So it really is looking at that opportunity for all of those individuals, both pre and post OSH level of services, so that our bed availability, if not able to return to what it was like pre-2012, which was primarily we had bed capacity to serve individuals under civil commitments in equal proportion as those under GEI, as well as aid and assist orders. It was previously, 1/3 of our beds were occupied by each of those patient population commitment categories. Whether or not we can get back to that stable state anytime soon is unknown, and at the same time, not likely, but having a larger number of our beds available to provide service to individuals under civil commitments is definitely the goal of OSH and OHA, knowing that it is the specificity of hospital level of care that is necessary.
Great. Who's taken part 2 of Deanne's question?
Can you remind me what part 2 of the question was, please?
Deanne, that was the, I'm going to butcher the acronym because this is not my space, SRTF? SRTF?
Yeah, so
ringing a bell.
It is. So we are actually working with SRTF providers to try to basically do that very thing, which is to have them serve clients at the level of care that they're licensed to serve clients. Currently now SRTFs are split into 2 classes. There's a class 1 and a class 2 SRTF. And so for those class 1 SRTFs, we do really want them working to their licensure. And so we are working internally with our Medicaid partners to ensure that happens, and also to really work around this idea of cherry picking clients. And so we have quite a few community outreach programs that we're doing. And then of course, working with our Medicaid partners will help. So that process is ongoing. It's just started with this new round of focus on that level of care. So hopefully things will start to improve in the communities as we move forward.
Thank you, Bill. And I'm taking notes, so we'll see if we can round some of this up if there's follow-up and the news is a recording. Jeremy, you have, I believe, the next floor question. Jeremy from HealthShare.
Yeah, thank you. And thanks very much for being here. I think Deanne largely asked my question, but, obviously we had Jeremy, Director Integrated Services with HealthShare, and, we had a large number of civil commitments that traditionally would have come from the Tri-County Metro region. We, have just over 400,000 covered lives at HealthShare, and last year we had 0 civil commits to OSH. And Unity Center, which is one of our primary facilities in the region, would have traditionally transferred a whole lot of folks to the OSH yearly. And so I just wonder, like, in terms of the capacity planning, and I'm really glad to hear about some of these new beds that are going to be opening OSH and in residential. Are you looking at like 2018, 2017, like pre aid and assist ruling data to kind of do some capacity planning for what would be needed to absorb what currently is like kind of isn't essentially happening? So I'm just hopeful that that's being taken into account. I know, I'm certainly hearing that a lot of folks are no longer pursuing civil commitments because they're not essentially going anywhere. It's not worth the work. So what's on the wait list isn't necessarily an indicator of what the demand might be. Yeah.
Yes, and we have heard the same in terms of the referrals for OSH services and the admission list not representing actual demand based on the circumstance that folks have been presented with over the last several years. In terms of capacity building across the continuum, the goal, there has been a huge amount of focus, as Bill has shared, around building that capacity for individuals under aid and assist orders. And again, by doing that in the community, that would provide the OSH service availability in terms of available beds. And we are always looking at our internal OSH data in terms of level of care, length of stay, what we can do to ensure that we are providing the best care possible, so that folks can return to their community, because again, our utilization management is important, obviously, for bed availability and bed use, and would love to get the continuum to the place that we would have more access and timely availability for individuals under civil commitments, and that is dependent on the larger continuum building. And I think, Bill, I think with the data and tracking your team and OHA is doing, it's kind of getting that larger kind of Oregon community numbers and needs for service.
Yeah, so as the, for example, right now we have a ready to place list that comes out of the state hospital for our aid and assist folks. And if we had capacity into lower levels of care that could take those folks, I think you would see a lot more movement of the civil folks into appropriately into OSH. And so we are working diligently on that list every week, trying to identify ways of moving folks out. So we're not talking about, if we could remove everyone off that ready to place list, I don't think that we would have a capacity issue at this point. So that's why our focus has been so heavily on aid and assist, because it's a complex process, but it also would create some of the room that I think the community needs at OSH for those civil patients.
Thank you.
This is Mike Franz from Pacific Source, Medical Director, Behavioral Health. Just to ask you just pointedly, is it the OHA and OSH's intended strategy to really move civil commitment, even at its highest level of need, into the communities, into the SRTFs? Or is it the intention, the strategy of OSH to get back to offering the kind of capacity that it once did for civil commitment?
from the OSH perspective, which is supported by the OHA perspective and strategy, as well as true goal is to have OSH beds available for individuals requiring hospital level of care civil services. Yes.
And that is the same with OHA. Our intention is not to somehow roadblock civil commitments into the state hospital. Ironically, I do think there is some concern that folks who don't get civilly committed when they need to be civilly committed then get released from facilities, maybe not perhaps as stable as they could be, and then enter the criminal justice system. And we really want to avoid that. So our goal is really truly to build downstream capacity for those folks needing lower levels of care, to open up the higher levels.
It's even more than that. I appreciate there's definitely that dynamic, but there's actually people that aren't even getting admitted to the acute care units who absolutely need to be hospitalized from a statute perspective and a clinical medical necessity perspective. But acute hospitals, A, don't have the space because they're full of civilly committed patients largely, or B, they're very reluctant to because they know they're committing themselves to 6 months or a year of having that patient on their unit. And so what's happening is these folks are getting discharged to the street from the emergency department. I think they're dying. I mean, that's the crisis we're at. So it's on all sides of the system that the pressure is mounting and that bad outcomes are happening. So I just want to make sure that there's no mistake about the dire state that we're in right now.
No, and I appreciate that comment. We hear that every day, and we're very, very committed to doing whatever we can to resolve this issue as quickly as we can. So I appreciate that.
Thank you for that direct and clear question and observation, Mike. I think it has been, we've had conversations about this and like this for many months. COVID hasn't made anything better. And we appreciate the ongoing efforts at OSH and Bill by your team, and the pressure continues to build. And so I welcome, I may have to confess, having a little less fluency in this space with all of the acronyms and the volumes and flow, but maybe you said this and I missed it. What is a time frame under which we might expect some beginnings of decompression that might be sensible by folks on this call? The CCOs are all represented here. I hear, and there are others also on behalf of fee-for-service and obviously across the continuum of care. Can you help us understand what we're, and maybe it's just me, but help me understand the time frame? Are we talking about months? Are we talking about having to hold our breaths and, like Mike said, see people discharged to the streets even into 2023 or beyond?
Well, so I can tell you that, so I've been with OHA now for 7 months. And in the 7 months that I've been here, and my team, to be clear, went from a team of 6 to a team of 12. So we've doubled our team. And we have really been increasing, we've done some incremental steps to increase capacity and increase flow out of the state hospital. But I think, I'm hoping within months we will start seeing maybe some of the relief. One of the challenges that my team has, and if we're wanting to talk about CCO specific issues, is that when someone enters the hospital under aid and assist rules, their Medicaid is suspended because they have been incarcerated generally before, and then they end up in the state hospital, which is still considered a level of incarceration. And so I think CCOs have been not reluctant, but they've not been engaged with those members. They don't sometimes know where they are. They maybe had been a member, their Medicaid gets turned off, now they're no longer a member. And so what we're trying to do at this point is see if there's some way of engaging CCOs to help us with some discharge planning challenges in the future. And I don't know if that is a partnership that folks are interested in, but I think it would be super helpful for us when we're talking about difficult clients to get out into the community, maybe having those conversations with the local CCOs.
Thanks. That's a helpful invitation. Anybody out there who wants to step into that? Deanne, I see your hand is up.
Yeah, I may be stepping into it in a slightly different angle. I've been working the Oregon system in and around the MHOs, the CCOs, running a CMHP. And so I'm coming at it from that perspective, which is I'm concerned with the extent that there is pressure to push for redundant systems. And I think that we underutilize the local mental health authority CMHP partnership, and that there are a lot of opportunities for an OHA CCO CMHP partnership, especially in looking at these types of complex situations. And that as the community behavioral health safety net provider, that the CMHPs are the most appropriate entity to really be responsible for the coordination of care and helping with the step downs and the transitions, rather than looking to have a variety of, if it's OHP, then it's this CCO. If it's not OHP, then it's the CMHP. Why would we set up two parallel systems rather than embrace a partnership and work with a safety net entity that could really do a great deal of good? Now, there is some funding that comes to the CMHPs, and the CCOs certainly do provide funding to the CMHPs as well. And I can speak for Yamhill that we definitely provide funding to our CMHPs to act for the CCO to ensure that these critical services are being accomplished by a single entity within each county. So I know that's a little bit of a soapbox, but it is an area that I'm highly concerned that if we fracture the system by having the CCOs do certain things and the CMHPs doing certain things, that we're doing a disservice to our vulnerable members. So I would sort of encourage perhaps those three-way conversations and finding a way to have that single entity potentially anchoring to more to transformation of the choice program. So thank you for the time to get on my soapbox there.
Thank you, Deanne. Anybody else in the last moments that we have the team here? Hearing none, I would like to express my gratitude. Dolly and Sarah and Bill, you're working in an incredibly difficult space, as are the CCO leaders on this call and so many others at this time. So I appreciate the work that you're putting in. I also appreciate a little clarity when you're able to communicate with us. And I know that a lot of this is happening in the behavioral health calls and not in QHOC. And so Dolly, I see your hand is up, and Lisa too, I see you. Dolly?
Well, I think Dolly and I have the same thing. So when Dolly and I were kind of just doing a touch base prior to today's call, and I think this is just, again, one of what should be future communications and discussions. Dolly and I had talked about how in prior conversations of different topics, whether it's out of hospital birth, heat-related extreme weather, I've collected point of contact for relevant leadership within OHA of CCO information or of individuals. And so Dolly, and Dolly can speak here, but Dolly has a list. I think, Dolly, you want to speak about the email that you have, and then I can facilitate getting that information to you. But
yes, Lisa, that would be great. And as Lisa indicated, we were talking prior, and one of the things I wanted to offer an opportunity for is kind of improved communication on our end from OSH. We have, for example, if we pause admissions or when we open bed capacity and or when we're turning the curve in kind of bed availability, we send out communications to a variety of stakeholder partners, and was just saying to Lisa that I am happy to coordinate with her to provide both written updates as we prepare them to this group, as well as kind of when we are making progress and or have new information to share. Would be happy to come back and provide updates as well, so that there is greater connection and understanding of what is maybe more current state and timelines for projected future state.
thanks, Dolly. So to that end, so, you know, the list that I have for QHOC is wide and broad. So when Dolly and I were talking about that, we talked about really, again, whom is the most appropriate person within a CCO to receive the Oregon State Hospital. Really, it's kind of like their current state update, which is, again, around bed capacity, things opening, not opening, whatever it might be. And basically, like in previous, each CCO will send a name, ideally a name and a title, to me, to Lisa Bowie, and I will collect those for each CCO, and I will get it to Dolly, and then Dolly will send it to her poor administrative assistant to include into their listserv distribution for their stakeholder groups when they have this kind of these regular updates about their changes. So if that's something your CCO wants to be in a regular updated communication from the state hospital, then please, again, send Lisa one point of contact with the person's title, and then I will facilitate getting that over to Dolly over at the state hospital. And then we, the chairs, as well as Dawn and I, will talk about kind of some next steps of when and what another behavioral health / OHSU, Oregon State Hospital. I used to work at OHSU. I'm not playing favoritism. It's just stuck in my head because I work there. Oregon State Hospital update will be next. So just stay tuned from your chair's discussion. And then again, thank you, Dolly, for making the time. And anything else, Jeannie, that you wanted to state while we still have Dolly? But that's kind of one of the next steps, is every CCO will give me a name to facilitate that ongoing communication.
I do not have anything to add, Lisa.
Okay. Dawn?
Thank you. Thank you to the OSH crew that came to facilitate, and let's move on. I don't know that I have a next slide. Do we have a next slide?
It literally just says COVID update. So there is no COVID slides. Dawn, you were, I think, going to speak to a few things. There was no official COVID update from the vaccine team. So it's just you've got the floor, Dawn.
Thank you very much. Hi, everybody. It's time for the masks to come off, I hear. As you may be aware, there was an announcement on Friday that masks are now optional in most indoor settings. They are still required in healthcare settings. I'm going to share my screen here for a few different resources that I want to be sure to share with you. The first is, so you probably saw, let me make sure that it's the right, I don't think that's the right one. Let's try that again. again. So the first thing that I wanted to share was where you can see the updates around the public health emergency and the mask updates. Here's the first link in the chat, and here's the second one. That is the bulletin about the RISE plan. That is the pandemic resilience phase is what they're calling it. So resilience in support of equity is the name of the state's pandemic recovery plan, which outlines near-term priorities that Oregon will pursue to monitor COVID-19, shield people at highest risk, reinvigorate communities, and repair the state's social fabric as public health interventions fall away over the coming months. There are 5 bullets that include protecting the communities most harmed by COVID-19, including distributing vaccines, tests, and masks to people at risk and priority communities through partnerships with more than 175 local nonprofits, health clinics, and other community groups. Protecting people most vulnerable, including tracking disease spread through wastewater sampling and maintaining a baseline capacity of vaccines, treatments, testing supplies, and lab capabilities. Expanding access to healthcare and supporting a thriving workforce, including maintaining or expanding coverage to as many as 350,000 people and distributing $200 million in workforce development grants, keeping schools open with a communicable disease management plan, and restoring social cohesion by listening to and supporting the priorities of local communities. So that's all on that second link. The next thing that might be of most interest to you is the details of what qualifies as a healthcare setting for application of that rule. I'm going to put that third link in the chat. And that, I think, will end my update for the broader version of the stage that we're in of this public health emergency. We do not anticipate that it will end until July. We don't have anything formal yet. We are working on a redeterminations plan. That is a partnership with ODHS and will be presented to ODHS and OHA Executive Steering Committee later this week. And will be shared more broadly after that. The redeterminations process addresses the increasing enrollment that has occurred in OHP. Up to nearly 1.4 million people across the state are members of OHP at this time. And that's because we have not been disenrolling since the beginning of the public health emergency. None of us are excited about withdrawing coverage from a bunch of people who have obtained it, and there are a variety of efforts to maintain and expand coverage in the ways that we can. So what was once Cover All People is going to be Healthier Oregon, and so on. And that will be part of this transition out of the public health emergency. More to come on details for that. Any questions on that before I move on to long COVID and paying for it?
Hi, this is Bhavesh. I just wanted to check back on that redetermination process, Don, about when is that likely to take place, and when will people likely get affected as members?
The redeterminations process, we have 12 months from the date of the end of the public health emergency to complete redeterminations, if I understand it correctly. And the examinations will need to begin those redeterminations will need to begin fairly immediately after the ending of the public health emergency. That said, the details of that are the plan that is being worked out among the execs, is being presented to the execs this week. And so I can get you more details about it once that level of evaluation is complete. But we don't expect the PHE to end until July, so it won't be before then.
Thank you.
Yeah. Anybody else? Hearing none, I will move on to the next topic, which is paying for long COVID. So there was a CMS announcement that came out last fall that OHP would be covering all things COVID, including long COVID. Of course, the clinical impacts of that are not very well understood yet. So it's hard to make clinical rules that support it. However, we have some policy rules in place that we can share. The recent memo that went out to CCOs on February 11th from Dave Inbody, CCO Ops Manager, described OHP coverage of post-COVID or long COVID treatment, includes the statements that CCOs must cover medically appropriate treatments for all post-COVID conditions, including condition and treatment pairs below the funding line of the prioritized list and other treatments that the OHP might not otherwise cover. The date that CCOs must begin to adjudicate claims in a manner consistent with this memo is today. So the OHA will work with CCOs on a case-by-case basis as needed, but the claims should have been covered for dates of service starting October 22nd through now. The numbers for those, for the CCOs are pretty small. I think the highest number is under 50 claims in one of our largest CCOs, and everybody else has fewer than that. Fee for service, on the other hand, has something like 200. Nathan, am I right? 200 claims for long COVID related services since October.
Yeah, that's right. We did a data pull from the end of October through I think it was about 2 weeks ago, and those were the numbers we found. We will redo that, and sorry to steal your thunder, Don, but we'll be getting specific ICNs to the CCOs and asking you to take a look at them for possible long COVID. So Don can speak a little bit more about how you will make those decisions, but I hope that's fair, Don. Otherwise, I can speak about it. But yeah, that is coming to you in the next week or two. A short list of claims for you to look at for possible medical appropriateness due to long COVID.
The memo outlines what the steps will need to be for post-COVID treatments you already cover. No changes, continue to cover those services. For post-COVID treatments you do not already cover, establish a process for making medical necessity determinations, communicate that process to your providers, use it to determine coverage. There are some bullets around not creating unreasonable or arbitrary barriers. If it is of interest, I'm happy to share the workflow that we developed at the state for the fee-for-service program, if that would be supportive to you. But the requirement is that there be medical necessity assessment for anything that prior to denial on a case-by-case until we establish a base of evidence that can do a better job of helping us more broadly define the coverage criteria. Questions for that, about that right now? Or Nathan, did I miss anything?
Nothing that I have, but happy to take questions.
In acknowledgement of the quickly changing and emerging nature of the evidence around COVID, my hope is that with our ongoing support around evidence review, as treatments become well-grounded, we'll be able to provide more guidance around that. We'll have to see how the evidence develops. Okay, I see a request for the fee-for-service guidelines in the chat. We'll go ahead and get those sent out with the meeting materials. Okay, the next thing that I have, the last thing that I have, excuse me, is a reference to a couple of job openings that we have at the state. We are going to undergo an effort toward fee-for-service transformation. That is to say, to transform the program that we have to provide care to those who are not enrolled in CCOs, toward equity, toward more value-based payment structures, and toward a more person-centered service planning kind of model. And there are two positions that OHA is hiring for. One is a clinician, a physician, MD or DO, to take the helm of that program and work from within the state to optimize service delivery. And that will include probably requesting additional resources so that the fee-for-service program has options like HRS to apply to our population. And there's also an OPA for operations and policy analyst level 4 position. So those jobs are posted, and the OPA 4 may be getting posted shortly. And we would welcome any referrals or references that you all wanted to send on for people who might be interested in working with me and with us to see what we can do next. And that concludes my announcements. Happy to take any questions at this time.
You like went right on time, Dawn. That's just kind of, I don't know if you intended to do that, but you know, nice work. Nathan, if you wouldn't mind emailing me the fee-for-service guidelines, that would be great. I'll put it in the follow-up email. And I'll take some of the links that Dawn's also put in the chat string and put those also in the follow-up email. So a whole host of things have changed, obviously, in this COVID world. So we all know that, obviously, as citizens of Oregon. So thank you for the update, Dawn. We are going to take a 10-minute break. Everyone can just get some fresh air, take a stretch break. Let's come back about 11:12-ish, to 11:12-ish. And we will come back to the HERC update. So I've also sent out a message to Dolly, so we'll find out Kevin's answer about whether we can get 2 people. I know part of this list is also, because again, it's about Oregon State Hospital, current state. So it really was around capacity of admin staff, et cetera, and scope. So I think she originally told me 1, but I will ask. I have asked, so I'll let you know. If we can get 2 names per CCO, but as of right now, it's 1, and we'll see if it changes by the end of the meeting. So everyone have a nice break. We'll see you in 10 minutes, and then we'll get all fun with HERC and P&T.
Thank you, Lisa.
So let's just see, let's just do a quick sound check. Dr. Jeannie Savage, you back? I'm just gonna say random names. Doug Carr, Bavesh, Joe, Laura's. It's just Ariel and I that are back.
You gonna have some pie today? It's pie day.
Is it pie? It is pie day. Oh, I should go to Loretta Jean's. Do you know Loretta Jean's in Portland? Okay. So I love pie. I don't like cake, but I like pie. And Loretta Jean's makes pie like my grandmother made pie. And it's vegan. I don't even know how she does it, but whatever. It's really good pie. And so I think I'm going to get some pie. But probably not going to make it up to Portland today. But if you are in Portland, go get some pie at Loretta Jean's. Except for she might be closed today on Monday. I don't know.
But it's pie day. She's got to be open.
Maybe she makes an exception for pie day. But I think she's normally closed on Monday and Tuesdays. I don't know. Maybe the Portland people on the call know. Maybe that's why I was going to make a pie. I could make a pie. So, are you going to make a pie, Ariel?
I went to the grocery store to buy a half a pie so that I wouldn't have a full pie, and I ended up bringing home 2 separate half pies because they had different kinds of pie, and you have to have a little of each.
What kind of pies do you buy? Which kinds?
Strawberry, rhubarb, and cherry. The 2 best kinds.
No, not those are so not the best kind at all, but that's okay.
Well, okay.
We still love you.
Yeah, huckleberry is over the top, the best kind, but you can't buy huckleberry pie. You have to find the huckleberries. And
yeah, no, these are not good choices. These are definitely not good choices. I think we should just stop QHOC and just talk about pie, but we won't do that. I'm sure everybody's here more for the rest of the QHOC meeting, and especially hearing about where the HERC meetings went for this month. Let me just do a check. Jeannie Savage, are you back on? Because you're just listening to us talk about pie right now. So
hey, people are commenting. They want to talk about pie.
Do they? Oh, you want to talk? Oh, pumpkin pie. Oh, and yes, for Loretta Jean's, thank you. And if anyone cares, my favorite pie is raspberry pie. There you go. It's not strawberry rhubarb pie. Who really wants strawberry rhubarb pie? I know, I just broke Ariel's heart. Oh, macadamia nut pie. That could probably be really good. Oh,
My husband's favorite is pecan, which I detest.
Oh, there's a lot of people who like strawberry rhubarb. Really? That's a thing, huh? Chocolate cashew.
Oh my gosh.
Ooh, so yeah, what's a hula pie? Is that a thing?
Yes. At Duke's restaurant in Hawaii, hula pie is, if you have never had it, you have to go have it if you go to Hawaii.
Which island?
What's in it?
Well, I think they have restaurants on the Big Island, and
they have one in Maui.
And on Maui. In Oahu, it's right downtown in the heart of everything. And you have to have reservations because you won't get in, but it's probably the best thing ever.
What's in it? Is it chocolate?
Well, it's macadamia nuts, chocolates, ice cream. It's to die for.
Yeah, I think I'm just going to whip up a pie since it's pie day. I'm going to go make a pie today, I guess. I wanted to make a pie yesterday, but I didn't. So I'll do one today. Thank you for that inspiration, Ariel.
All right, so that I don't bump poor Roger's time completely.
Oh, we've got more than enough time today, by the way.
Okay.
So yes, look at all these lovely pie choices. This is like a nice little waterfall of pie. Okay, so Ariel, you've got the floor. Welcome back, Jeannie. It's pie day. I didn't realize that, and that's why we're talking about pie now. Mud pie. I agree with you, Roger. So we're going to talk. First, we're going to talk about HERC. Then we're going to talk P&T, and then we're going to just randomly talk anything that's left over from the floor. And I can't remember if Dawn had anything, so there might be a little bit of HSD updates. And if not, then we'll finish maybe a little bit early for lunch. We are having a QPI session today, and we are talking SUD statewide PIP brainstorm topic. So Ariel, you have the floor for whatever topic you want to go with.
I would like to talk more about PI, but I should give you a HERC update. So why don't you go ahead and advance the slide. The HERC met last week, so you'll, and COVID codes can, seriously, they continue to breed. Last time I told you about a couple of new pediatric ones. There are 2 new ones for the Moderna vaccine, which kind of undermine my faith in humanity, because apparently people are having trouble drawing up a half dose out of the regular Moderna vial. So they're now coming out with diluted down to 50%. So you can draw up the same dose. Anyway, different code to do that. So there's 2 codes for that. That's the Moderna booster, the vaccine, and then the administration. And then they came out with a new lab code for mutation identification. So this would be for looking for variants. We consulted with our public health colleagues. We are in the state of Oregon testing for variants in about 6% of our samples, but we're doing it through either the state lab or through some of the bigger health system labs with CDC grants. So currently this is not a patient care thing. This is more of a public health thing. So we had a debate at the meeting about whether we should put in the diagnostic procedure file. We added it, and then next slide. We updated our guideline to say we only want this if it's going to be required to guide patient treatment. So our public health folks told us, in the future, if we had a situation where, say, Delta and I don't know, Zeta and Tau, I don't know, 2 different variants were out there, equally probable, and one responded to a certain antibody treatment and one responded to a different one, then it might become clinically important to know which one a patient had. So that's why that we put that in the guidelines. So if you start getting requests for this, it shouldn't really be covered right now because Omicron is the overwhelming variant. So we don't really care. We're just treating based on community, the spread or with the community prevalence. But again, it could be useful in the future. Next slide. So we actually made it through our agenda. We updated our Botox guideline just to add a couple of below the line lines that were just not included, just to kind of for completeness. Intrahepatic arthropathies are inflammatory joint conditions that deal with autoimmune gut disease. We ended up doing a really extensive below the line review because of a lot of advocacy work that was being done, particularly by pediatric advocates. So some of these things are just things we found on a below the line that didn't belong there. So that was one, we put that on a covered line. Erythropoietin and chronic kidney disease, this actually got tabled. So if you looked at the meeting materials, there was a CCO pharmacy request to cover just sort of generic chronic kidney disease in the EPO guideline. But it turns out that it's more complicated than that. So that's got tabled, and you'll see that probably on the May meeting agenda. It appears that specific code for chronic kidney disease is actually for EPO resistant chronic kidney disease. So we're probably not going to make any changes, but we'll decide that at the May meeting. Pelvic congestion syndrome, we just added a guideline specifying that it is included on the lower pelvic pain line, doesn't pair with treatments for vein ablations or types of things. Platelet-rich plasma, we currently have 3 specific uses that we have said we don't cover, which is near osteoarthritis, wound care, and low back pain. So we added the generic temporary CPT code for platelet-rich plasma to guideline note 173 for all other indications, because we didn't find any evidence for any indication. If you hear of a complaint from a provider about it and you find an indication that does seem to have reasonable evidence, let me know. We can always look at a specific indication. We looked at breast reconstruction after lumpectomy. It was unclear in our breast reconstruction guideline whether we only cover reconstruction after mastectomy Lumpectomy has the rather bizarre CPT code of partial mastectomy, which in my mind is a completely different procedure, but I don't make up CPT codes. Anyway, so there was a question about whether this partial mastectomy or lumpectomy would qualify for breast reconstruction. And so we just clarified in the guideline that it does, partially so that we don't have a sort of a perverse incentive for women to have a full mastectomy when they could easily have had a lumpectomy to treat their cancer. And that's both to reconstruct the breast that had the cancer, as well as any procedure on the contralateral breast for symmetry. The breast MRI guidelines, we have 3 currently. They're very confusing. I've had tons of questions from the medical directors about how they relate to one another and when we cover. So we basically deleted 2 of them and made sort of a big, long master breast MRI guideline. It covers when we cover screening, which hasn't really changed. It does cover a couple indications for preoperative screening, which we previously weren't covering at all. The first indication is when people would otherwise have qualified for it for screening. So let's say they're BRCA positive. It seemed really unfair to allow them to have an MRI for screening, but as soon as they have a screening mammogram and they find the cancer, then they can't have the MRI. The other indication was actually brought up and modified during the meeting, and that was this very extensive set of very rare circumstances set forward by the breast surgery guideline for, when there's multifocal areas of concern, looking for the underlying thing for Paget's disease, other things. So they're all in the minutes when you get the minutes, which will hopefully come out by the next meeting. But you can see there's certain circumstances, and hopefully that will help you all in your reviews. And then we talk about a couple other just really specific conditions, and like suspected breast implant rupture, when you can't really get a good sense of it from other imaging, if it's going to affect management, or if you have a suspicious lesion, you've done all the imaging possible, you can't do a biopsy for whatever reason, then we would cover it as part of a diagnostic workup. So hopefully that's helpful for you all, and hopefully that will answer a lot of your questions. When you see that new guideline, if you have questions or you're still finding it difficult to use, or you're finding situations where you're still having a lot of questions brought up by breast surgeons or radiologists, please let us know, and we can always look at the guideline and update it if needed. We reviewed actinic keratoses. We don't cover them. We are just updating our review because it's been more than 10 years. We still don't cover them. There's actually a really good RCT through the VA where they randomized people to different groups, and the group that got no treatment but sunscreen did the best. So give everybody sunscreen. Radiofrequency ablation and cryotherapy for select renal cell cancers. So we added these. These are minimally invasive treatments for renal cell cancers under 3 centimeters in people who aren't good surgical candidates. There's a guideline kind of outlining that. We clarified our lower urinary tract symptoms guideline. I think this is going to be is pretty helpful. Brian Duty, who's our urologist, kind of helped us sort out when we actually would cover this and what we mean by like drug trials and things like that. So hopefully that's helpful for you all. We looked at sensory integration therapy, and we are continuing non-coverage. We looked at congenital foot deformities, and actually that item got tabled. I was requested to talk to an orthopedist or podiatrist just to make sure we got the codes right. So if any of you guys have someone who is a orthopedist or podiatrist who's a good foot surgery person, please send them my way. I'm going to need to just have a brief consult to make sure that we are covering the appropriate things and not covering the appropriate things. Then we looked at gait analysis and surface electromyography. These are things usually done for like preoperative kids with CP assessment, et cetera. Didn't find evidence that this really helps surgical outcomes. So we've actually put them on the non-covered guideline note 173. And then we clarified our polydactyly coverage. We currently have polydactyly on a covered and uncovered line. The intention is to cover, so we just removed it from the uncovered line to hopefully remove that confusion. Next slide. And then we had a couple things for our 2024 biennial review. So everything up to this point should go into effect October 1st. these will go into effect January 1, 2024. We're getting rid of our agenesis of lung line. The only code on that line is actually also on a covered line. We can't do anything about the fact that you don't have a lung, but we can give you DME or other services. And then the other line that is going to be deleted with the 2024 review is dorsal rhizotomy for spastic diplegic cerebral palsy. And that's because we added dorsal rhizotomy to a covered line that also had spastic diplegic cerebral palsy with a new guideline. You have to be between the ages of, I believe, 2 and 10, has spastic diplegic cerebral palsy, and there's several other criteria for when we would cover this procedure. So that coverage will start, I can never remember if it's October 1st or January 1st for new things like that. But you'll continue to see that line kind of crossed out on the list until 2024. Next slide. Our May agenda is slowly shaping up. We've been asked to look at bilateral BAHA, which is a hearing thing. We are updating our new orthodontia guideline to get rid of all of the sort of like, you don't have to have a scoring. You automatically get in with these because we were told that that's not not very easy to administer. So you'll see that that should be pretty straightforward. We've been asked to look at different imaging for coronary, for heart things. We're going to look at that at some point in May or maybe a little bit later. Gastric neurostimulators, I initially had put this on our, we don't need to look at this because it has only humanitarian use exemption FDA approval, not actual FDA approval. And we're still working out with leadership and legal stuff about whether that actually is true. Apparently, we actually can cover things that have FDA approval, even if it's just the humanitarian approval. So more on that later. Ophthalmology visual field testing. We have a very we have an ophthalmologist who's quite interested in expanding coverage of visual field testing. Currently, it's paired with certain diagnoses. She feels this should be more of a diagnostic test because it's used and for both diagnosis and follow-up of multiple conditions that deal with the optic nerve. So if you have any strong feelings about visual field testing and how it should be covered, let me know. And then the adenoidectomy guideline, the pediatric ENT folks have updated their guideline. Our current adenoidectomy guideline is basically the older version of the same guideline, so we're just updating ours. It will allow adenoidectomy with the first PE tubes or tonsillectomy because of trying to minimize the risk of anesthesia multiple times in kids that are higher risk for probably needing it. Temporary urethral stents, there's a question about whether we cover those, and we don't. That will be coming in May. Next slide. And that's the current May agenda. Oh, and then MRI and MS is one of the other things that we are reviewing. I know that that's been a real hot button issue. So if any of you have any neurologists who are very passionate about MRI for MS, I know we've gotten a lot of feedback from the HERC that we should be allowing yearly MRIs. We currently have a guideline that says that we don't do that. We've been asked to re-review that, but if you have any neurologists that you feel would be good for me to talk to, please send them my way. I'd love to, just run some things by and get a better sense of what's really going on in the world of MS currently. Okay, and then of course there'll be more topics by May, and please send me your topics. So going back to the evidence-based guidelines subcommittee, and I realized I even typed out the name of our subcommittee wrong. It's EBGS. EBGS will be meeting in a couple weeks on April 7th. It's a virtual meeting. The main topic will be PANDAS. That is pediatric autoimmune neuro disease after streptococcal infection. we have a proposal that will be debated and possibly voted on that will cover IVIG and plasmapheresis if it's recommended by a pediatric subspecialist and a PCP. This is a little different. Our previous draft had 2 pediatric subspecialists, but we heard from specialists and patients and advocates that that's a really, really difficult hurdle. And so this will be 1 pediatric subspecialist and the PCP. And the child has tried and failed 2 less invasive therapies, such as NSAIDs, corticosteroids, antibiotics. And there'll be a requirement to reassess every 3 months. And that's going to be needing to use an objective tool. And that tool should be based on whatever is the presenting symptom. So if it's mostly OCD, then it should be an OCD scale. If it's mostly anxiety, then it should be an anxiety scale, et cetera. Continued non-coverage for surgical interventions like tonsillectomy and for long-term antibiotics. There has been a large volume of public comment received. So a lot of this is based on a lot of that comment. Next slide, please. EBGS will also be re-looking at high frequency chest oscillation. I know I told you last month that we voted this out. We were, the recommended coverage was for CF, bronchiectasis with evidence of chronic lung infection, or neurologic disease with evidence of chronic lung infection. However, we had the Center for Evidence-Based Policy, who did our deep dive evidence review, found some last-minute errors in their review. And because they substantially changed the evidence review, we are taking it back to EBGS just to I don't think it's really going to change our recommendations, which are mostly expert opinion based, but that will be rediscussed. And then we are currently in the midst of scoping 2 topics, continuous blood glucose monitoring and bariatric surgery. For bariatric surgery, it's both type of procedure and location, whether that needs to be a center of excellence, whether it could be an outpatient center of excellence, et cetera. I believe those scopes may be open for comment. You can always look on our website and see if you have any burning comments on either of those topics, and look for those to come in the fall probably as coverage guidances. Next slide. And then we are always, geez, I don't know how to spell my own subcommittee. EBGS is always looking for future topics. So please, if you have topics either for VBBS or EBGS, please send them our way. Next slide. This is how to get hold of us. If you have a choice, please send things to herc.info, because that will always get to the right person. Oh, and before I give up the mic, I just wanted to announce we're very, very excited. We have hired a new associate medical director, assistant, or I'm not sure what her title is actually. She's going to be working for us a quarter time. And hopefully at the next meeting, I can officially announce who she is and maybe even introduce her to you all. But we are absolutely thrilled that we are having a little bit more help at the HERC. And once we introduce you all, you'll have another face and contact person. Any questions for me? Topics, clarification. Favorite pie?
Ma Brown's huckleberry pie from Whitefish. She made it with bear fat. It was the best huckleberry pie ever. Can you hear me okay?
I'll stick around for the 12 o'clock questions in case you have anything.
Everyone's reflecting on bear fat, Roger. They're just like, that sounds interesting.
Old school trick, apparently.
You know, my grandma's trick was Crisco. You know, the more you used it on everything, it's kind of like the
crispiest crust.
Exactly. It's like, you know, if you ever watch My Great Big Fat Greek Wedding, you know, they use Windex on everything. That's the running joke in that movie. My grandma used Crisco on everything. Crisco, Crisco, Crisco. Okay, we're gonna now transition from, you know, bear fat and Crisco conversation to P&T conversation. So you've got the floor.
Well, I'm between everybody and pie for lunch, so I'll make it quick. It was a pretty straightforward P&T committee meeting on February 3rd. Recommendations were approved by the director on February 9th, and that's a link that I'll put forward just so people can go see the recommendations on the OHA's webpage. Next page. And as part of all of our P&T agendas now, we try to be a little more efficient by having consent agenda topics. One of the standing ones is oncology policy updates. So when new drugs come to market or new indications are obtained by certain drugs, we add those to a table in our criteria. That way we don't have to perform a review, and it just lets us be a little more efficient and nimble. And this is a link again to our searchable web application where you can find the agents and get a link to those PA criteria. Next slide. Also part of the consent agenda, we do literature scans. Standard is we do a scan, and if we don't see any compelling evidence to make changes to either the PDL or essentially to the PA criteria, we can add it to the consent agenda. So in this case, we looked at parenteral antipsychotics. So again, no changes were recommended based on the clinical evidence. We did review costs in executive session, and there's a new Invega offering that we added as a preferred agent on the PDMP. Has a unique name, Half-Ura. If anyone wants to guess, yes, it's dosed every 6 months. And so this is, again, one last link to provide you to our web application where you can see the PDL status and the associated PA criteria. Next slide. Also part of the consent agenda, we looked at the inhibitors of the RAS system. So when we were reviewing the ACE inhibitors, ARBs, direct renin inhibitors, no changes were recommended based on the clinical evidence. We reviewed prices again in executive session and recommended fasinapril, quinapril, and candesartan be made preferred on the PDL. Next slide. We did do an update to the RSV, our policy. So we looked at the literature scan, but because of the variation of onset and RSV in the communities across the nation, we decided to look at this, and we made minor modifications in our recommended season onset guidance. We do look at the weekly surveillance that comes out from the OHA just to see when the PCR or the testing indicates that there is a season offset. An onset. I think we just had a recent season offset. So kind of a funny season this year, and you're probably all experiencing in your own plans as well. But nonetheless, we wanted to update our criteria so we could match season onset and offset. Next slide. We performed an oral antifungal class update and new drug evaluation. No changes were recommended, again, based on the clinical evidence. Recommendation was to maintain Brexafemme as non-preferred. Again, new agents that come to market in a PDL class are made non-preferred until reviewed. In this case, we just closed the loop. We did review costs in executive session, and no other changes to the PDL were recommended. Next slide. Performed a Pompe disease class update and new drug evaluation. In this case, we recommended alpha-glucosidase alpha be added to the lysosomal storage disorder class and designated as non-preferred. We updated the PA criteria for the Pompe disease drugs, so it could include the alpha-glucosidase. Looked at the pricing in executive session. No other changes to the PDL were recommended. Next slide. Performed an immunosuppressant class update and new drug evaluation. Kind of a recurring theme at this last meeting was pretty straightforward. No changes were recommended based on the clinical evidence. We did move Safnello into the targeted immune modulator class, a little more appropriate. We added belimumab PA criteria, and we implemented the proposed criteria, prior authorization criteria for voclosporin and anifrolumab. We looked at costs again in executive session, and no other changes were recommended to the PDL. Next slide. We performed an oral glucocorticoid class review. We hadn't actually already included this on the PDL, so we did elect to include the oral glucocorticoid class, really large, on the PDL. And the recommendation at a high level was to designate at least one oral formulation of each glucocorticoid preferred. We looked at costs in executive session. In this case, we kind of made a recommendation in reverse order. We recommended the following agents be non-preferred. So these are more of your branded, more expensive agents: Hamedi, Alkindi, Sprinkles, Pediapred, Millipred. the prednisolone sodium phosphate, and the disintegrating tablets. So then all of the remaining agents in the class that were currently available were going to be made preferred. So a little more easier way to make that recommendation. And that was it for the clinical information we presented to the committee. Next slide. The next meeting of the P&T committee will be on April 7th. We just posted the agenda and the final documents last Tuesday. Again, if you want to see that agenda and the documentation, supporting literature, that's out there on our website. Here's a link to that. Any interested parties are able to Zoom in, participate. It's open to the public. And we also open it up for public comment. People just need to give me their conflict of interest declaration. We'll provide them up to 3 minutes to address the committee during discussion on topics. Next slide. We are still looking for 2 physicians to fill vacancies on the P&T committee. That's for the physician position, either MD or DO, need to be actively in practice, do not have a specialty, just a basic understanding of evidence-based medicine, and an open mind just to provide their input. We have a great committee. They're remote meetings, so it's not too onerous. Terms are for 3 years, and we have 6 meetings a year, but it's really important work. So if you have any physicians in your network of physicians might be interested in this, they can always shoot me an email, ask me questions. I'm happy to discuss, what the role entails. And then through the OHA's website here in this link, there's an application, pretty straightforward. Just want to make sure that we see conflicts of interest being disclosed. Next slide. And with that, see if there's any questions. All right, thank you all very much.
Thanks, Roger. It looks like we still need to try and help find him some doctors to sit on that committee. Roger, maybe I'll touch base with you and we can see if you can get something in the OMA newsletter, maybe, or something of that nature, because I know you've been looking for a bit.
Yeah,
so
Trevor's been
maybe
looking and he's got things he's been soliciting. It's out on his webpage. But
okay. Well, drop me an email. We can also connect you with some OMA folks as well, and see if there's any outreach efforts on that side of things, not just with the CCOs, although the CCOs can also equally forward you any names they may have. Hang on, let's see. I think David just dropped in a message.
yeah, just
Great
say the
job.
words fast with conviction, even if they're wrong, just blow through them.
Well, and you made them sound all like, very scientific. So maybe you didn't even pronounce them correctly, but you probably did. So nice work there. Any questions for Roger or Ariel on any part of the updates that they had? Okay. Well, I'm going to go ahead and give you just a few updates that we have from this afternoon for those that are not joining the afternoon, and then we'll just kind of open it to the floor. So for the SUD PIP this afternoon is our first kind of, I guess you can call it, collaborative kickoff meeting to talk about brainstorming the topic. Just FYI for everybody that's on the CCO side, just so you know, we are following a very similar timeline to what we did almost exactly a year ago, which for the integration statewide PIP, we will be working towards a September 1 validation submission for the design phase of the SUD statewide PIP. So this is the first of the SUD statewide PIP. So again, this is a reminder that the agency had the SUD waiver approved last year. In that SUD specific waiver is a call out to a second statewide PIP. That statewide PIP design phase discussion begins today at the QPI session. The steps towards the design is collaborative through OHA. The validation submission will be September 1 by CCOs to the agency, and HSAG will be the reviewer and validators of those submissions. The conversations this afternoon will be really pretty much a brainstorm session on topics, so all are welcome. And then I will be doing just a brief presentation, just again a reminder of the SUD waiver and the process that we're undertaking although we're now have done this for the 4th time on an SUD or on a statewide PIP design. So we are all, if you've been around for a bit of time, all professionals at this. So that's where the SUD statewide PIP is at. The only other update that I have that's kind of relevant is if in fact, what was the other one? Dawn and I said we for things that were kind of left over from previous QHOC, we obviously had the Oregon State Hospital update, and we know that was kind of one of the, I know the other was one of the other hanging things. The other update we had that was kind of specific to all of the audiences of CCOs is next April. The QHOC Learning Collaborative topic is initiation, engagement, and treatment of alcohol and other drug disorders. So it's the IET measure. So I have emailed the chairs as well as the quality folks specifically within CCOs around the format of that particular learning collaborative. We could go a couple different ways with that. So if you have not responded, would appreciate that. We are also looking for any particular practices that are not integrated, that are doing well or are willing to talk about some of those barriers related to the IET metric. So the IET Learning Collaborative is next April, or the next QHOC in April, and we've got 2 proposed formats, and each CCO's quality staff have received the kind of formats and looking back for your feedback on that. Holly Jo?
Hey, yeah, Lisa, I'm just wondering if I missed it somewhere, but we had parking lotted now for almost a year, the discussion around developing some form of a unified methodology to deal with patients who are staying in the hospital beyond when they meet acute inpatient stay criteria. Where are we at with that? We've been hoping OHA had a work group working on how to pay hospitals for the level of care they're giving, such as SNF, if they're just waiting to discharge them.
Dawn, I believe we looked at, I'm going to punt that to Dawn. And so first off, Holly Jo, last month, we did receive information from our partners over at DHS about guidance, not related to the payment, but related to if SNFs are, let's say, denying patients transfers for reasons and maybe not following the state guidelines that are put out there, then we received that guidance from DHS as far as what a CCO should do if in fact you're hearing the SNF not following transfer approved procedures. So
yeah, that's great. That's not what we need though. We need
then the payment structure, I believe, Dawn, was something that was talked about with Washington, I believe. I'm gonna let you speak on that one.
Yeah, thanks, Holly Jo. The question of custodial care or custodial levels of payment being worked out with hospitals is when obviously the congestion in the discharge pipeline has brought front and center the last that we were talking about it, the CCOs were each working out with their hospitals with their contracts those levels of payment, and that was typically what we heard both from Washington, which has a state admin level, admin day, or custodial level of care day rate that is standard across the state, but that was as close as we got to more guidance for the CCOs. The rate is a function of the negotiation between the CCOs and the hospitals, and that is, I believe, as far as we.
So
Dawn,
what I think what we're looking for is a unified process, because what we get on the CCO side when we reach out and try to say, hey, we want to pay you for the SNF level of care. There's something to do with the billing on their side, and the fact that they are not accredited to provide that level of care. They're not able to bill us for that, and that's where it just sort of breaks down for a lot of us. And I think that from my previous conversations with the CCO medical directors, we would all like a unified process for dealing with this up and down the state, so that everybody is doing the same thing. I mean, I realize there's people that are doing one-offs here and there that have been somewhat successful, and I guess maybe we need to hear more from them. But the medical directors, I think, were loud and clear last month when we were all together in our meeting that we'd like a unified direction coming from OHA. And again, it's about that billing part of it. I recognize that contractually, we can develop the rate, or there already is a SNF rate, so it's not that difficult. It's how to complete that whole billing part of it when the hospital doesn't think they can bill for it.
I will take that back. I thought that some of those things had been worked out already, and I will take that back. Thanks for reminding me that you haven't got what you need yet.
Yeah, Dawn,
and
that
if I
may have
missed the
been,
boat, somebody else chime in.
no, I think we had the discussion, and it may have been my inability to bring that information back with a clear request, Dawn. I think we had a discussion about what all the CCOs were doing independently. And my takeaway from our conversation from the CCOs was, yes, a unified approach. Everybody's doing it differently. But my takeaway from your work, Dawn, as well, was that you were investigating with Washington and considering getting that into a more kind of rule-oriented, yes, we're going to have admin days in the state of Oregon, and this is what we will pay for admin days, or we would like to agree on those kinds of things. So it's probably just my inability to connect those two conversations. So apologies. But yeah, I think Holly Jo did state that well. Their CCOs don't really want to do things differently all around the state. I think we would rather try to have a universal approach and agree with the state on what that might be. And I can continue to work with you, Dawn, on making sure that I do better and taking the information back and forth.
Thanks for stepping in there, Jeannie. I'm happy to follow up.
Before we move on from this topic, Dawn, I just want to make sure I capture in the notes and follow up clearly, because I'm looking at my notes, Holly Jo, from November on this topic. So I just want to write it down so we know exactly what we're following up on. So, unified process approach for negotiations with hospitals on payments when members cannot be transitioned from hospital to SNF. Is that sound about right? Or
I think it's a coding, and it's on the hospital side as far as coding and billing and accepting payment for a level of care that they may not be currently accredited for. And again, this remains our biggest problem in getting people out of hospitals still.
Yeah, I think that the coding issue becomes less than the hospitals, if they agree.
It's probably for the credentialing.
Well, no, I think, Lisa, we can circumvent that whole thing, because if the hospital agrees to a case rate or an administrative day, then they cannot go back and appeal from what I understand, they cannot go back and dispute the payment they received before either. So they're basically saying, okay, we saw the patient for these 10 days. We agree that we get an inpatient rate for those days. When the patient then went to an administrative rate because they were unable to be placed, my understanding is that if they agree to that administrative rate, then they can no longer dispute the payment from what happened before. So that I may not have that correctly, but from what I understand, it's basically saying, okay, then we agree to only that inpatient rate for those 10 days, and we agree to this administration rate for these next 10 days. And hospitals may not agree to that administration rate. They may not like that rate because they still have to provide, based on their people issues and what they staff and so forth, they still have to staff accordingly to a med-surg bed. And so hospitals may not be willing to say, okay, well, we'll take that admin rate. But the reality is if you take that admin rate and still provide higher touch care, then, you know, the hospitals see that as a disadvantage. So I can see where it needs to be something that hospitals and payers get together on and make an agreement that this is an acceptable option. So I think it's a little less of a coding and much more of an acceptable rate outside of what the service is really being provided.
But then to that point, Jeannie, then is it that you're asking for the state to come in and help facilitate an acceptable rate at a statewide perspective?
Well, I think the
you know,
idea,
rate versus process and billing, those are two different conversations.
Mhm.
I mean, you right? I mean, this is the crux of making sure Dawn is equipped with the right task, is what I'm trying to you know, because first off, normally we don't talk about money here, but I understand that the problem that you're all trying to fix, which again, we're not going to fix it here, but is the problem that hospitals are saying, hey, I can't do this because I don't have a level of service billing code under my scope of practice, under the scope of credentialing, under the scope of codes that are available to me for the individual, for the kind of care I actually am delivering at the rate that I want to get paid for? Or is it that, no, I got all these codes I can use, but I don't like the rate?
it may be both. I don't know. Because when we reach out, we don't ask them for any sort of billing codes. It takes it out to a separate arrangement. And that arrangement then is not something that they have to bill codes with. It's an arrangement outside of that, like it's a special contract.
Yeah.
Right. So
and when you're
I don't know.
negotiating this at the individual level, I mean, individual level CCO to individual hospital system, and, you know, CCO's contract with multiple hospital systems, et cetera, then you're having this conversation however many fold over. It may be that one hospital knows what codes to use and one hospital doesn't know what codes they would use, and one hospital is accepting of the codes and or the rate, and one hospital doesn't even know the codes and doesn't like the rate. I mean, there's a whole variety of scenarios that could play out in this.
Yeah,
that you
agreed.
all are being faced with. Is that what I'm understanding correctly?
Yes. And yes.
Okay.
And we're not doing that consistently. And I think the other issue was that we had an example next door in Washington where they had worked through this process and come up with something and made a statewide plan with their Medicaid program. So I thought it might be a good idea to probably look at what they did and then bring that back as an option to kind of investigate with our medical directors and maybe our state.
Okay, so the key question, Dawn, would be, number one, did Washington, when they came up with this administrative rate, did they come up, or administrative day billing function, did they come up with administrative rate across all hospitals, across all payers? That's like two maybe questions in there. So hopefully you wrote that down, because I'm thinking, not typing. And then, so that's the question to Washington, right? And then there's this question of Oregon, of number one, is that a space Oregon's willing to go to? Not Oregon, like I mean, it's OHA / the Hospital Association, a bunch of people that aren't even on this meeting, to be honest, right? And then, like I said, we don't usually talk rates. So then there's a bunch of people that aren't even on this meeting that need to have this conversation that Dawn gets to go, you know, Dawn and I will try and go have this conversation with, saying, here's the problem that the medical directors are being faced with, or the CCOs from the clinical side. Here's some solutions. Here's one example, which is Washington, what they did, and go from there. That's what I'm hearing.
Agreed.
If
And a lot of
anything
that
is wrong on that, put it in the chat box. But that's what I'm going to work with Dawn on, with OHA leadership first, and see where and what direction OHA is willing to go into this space or not willing to go into space. I don't know the answer, but I at least will be able to hopefully present the problem in a way enough that makes sense.
So
a lot of this conversation has already been had. We talked with Washington. We have a sense of what they do, and some of that information has been brought back. But it was not clear to me that the loop had not been closed in a way that met the needs. of the CCOs. So I'll go back and pick up that conversation where I left off with it and follow up with Dave Inbody and the rest of Medicaid leadership, as well as more OHA leadership, and see what next steps need to be to provide more guidance, because it sounds like the statewide approach is going to be necessary. And if the CCOs are to be more consistent and expect partnership from the hospitals across the state, I'm not sure whether we can. Yeah, I need to talk with the other leadership members to see what we can swing that way.
And it seems like, Dawn, from the side of the CCO medical directors, then as you're working on that, what I need to clarify with our group is, it, like Lisa and Holly Jo said, is it really just help us negotiate a standard process to work through, like, okay, CCOs and hospitals, here's the process we'd like you to work through when you are experiencing this issue. Members can't get out and get placed. They're basically in the hospital with no medical necessity criteria, but they do not have a safe discharge plan. Here's the process we'd like you to undertake to go through in order to make sure that we are supporting each other as payer and hospital, and supporting the member to make sure they get the appropriate care, versus do we want you to negotiate a standard rate that we would all agree to and pay? Because it sounds like I need to clarify that with the medical directors as well.
Yeah, because process makes sense, right? Setting up some common agreements about here's how we come to the table when, gosh forbid, another surge, right? Like, if something were to happen in the environment where we can't, take people away from, or can't, get people out of the hospital into SNFs, whatever that might be, weather related, COVID related, whatever. So here's how we come to the table, payers and hospitals, right? And SNFs. There's that process, but then there's the rate part of the conversation, which is just whether Washington did that or didn't do that. I don't know what Oregon's appetite is for that. And those are two very distinct conversations. And so, Jeannie, you get to have that conversation with your CMOs and let us know. And you let Dawn and I know at our check-in which one it's feeling more like. Dawn has already engaged, like I said, several emails, and that includes the one with Dana Harganani, Dawn. So don't forget, that's the thread we should follow. And then I will help y'all, because if it's process, and I'm all about process. Let's figure that out. We can come to some agreements, because we might need these again. But if it's about rates, I honestly don't know what the appetite for that is. So just putting that out there. Okay, Holly Jo, any last thoughts on that before we follow up with Jeannie, or Jeannie follows up with us on that, and Dawn and I resurface that email chain with Washington? Okay, I think Holly just says,
sorry,
great job,
yes, trying to get off mute. That sounds good. Good plan.
Okay, thanks, Holly Jo. Does anyone else have anything else from the floor that has been outstanding, or things going forward? Anything related to the IEP Learning Collaborative you want to put forward, then definitely put it in the chat or email me. If Doris is still on the line, and I think this isn't related to the Oregon State Hospital point of contact for CCOs, I put my email in the chat string. You can also find it on the QHOC website. You can just, the OHA question box goes to me as well. So I have not heard back from Dolly in regards to that point of contact and having two names. So at this point, please send me one name for the point of contact. I do know that she wanted to make sure you guys got on the list as soon as possible so that you can continue to get those updates about, bed changes and capacity changes. So as soon as y'all get me your names, then you'll start getting the updates, whatever. I don't think they come out like on a weekly, I think they come out just as things change, as current state. So it's not like the CCO weekly update that comes out every Friday. It comes out when the circumstances change. Anything else, Jeannie or anyone else?
Not for me, thank you.
Everybody gets 20 minutes to go bake a pie.
Eat a pie.
Eat a pie. That's if they made their pie or went and bought their pie ahead of time. Okay, so as a reminder, we will be having a 1 o'clock session on Exhibit I, complaints and grievances, and SUD statewide PIP development, and just general QPI session announcement. So I will see some of you at 1. Please do not put your phones on hold, because that's just, you know, not really fun hold music sometimes. So just hang up and dial back in at 1. You all can have a lovely extended lunch, and we will see some of you back in April if you're not joining the afternoon session. Thank you. Happy Pi Day. QPI session. So we'll just give it a little bit longer just for others to join. So just give me a second. Laura, are you on our chair for the QPI session? I'm here. Hello. Looks like we still have a few people joining in the wait room, so we'll just give it a second still. Okay, it doesn't look like there's anybody else hanging out in the wait room. So, okay. So just as a reminder for tips for meeting participation, please keep your phone on mute unless you are speaking. If you are having difficulties unmuting your line, if you're calling from a phone, you might want to try *6. And you can use the raise hand functions, which is under the reactions button. If you have a question, or you can always put questions in the chat string. And always, if you can, please try and state your name and turn on your camera. It helps with the engagement of the conversation. So I am Lisa Bowie, Quality Improvement Director, OHA. I'm wearing dark glasses and have bright red lipstick on and a black shirt. We will go ahead and advance slides. I'm going to go over just a couple updates, and then we'll just get right into today's agenda. A few updates and reminders. For a couple emails have gone out. Just want to make sure people have those. First off, in regards to the 2022 TQS Transformation Quality MEP review, MEP component review. This was announced during one of the TQS office hours, and I just wanted to make sure I mentioned it here as well. The MEP component, if you happen to submit your MEP report through TQS in the utilization component, then you are, again, more than happy to do so. We wanted to let you know that the review will be done by our outside consultant who is working with the actuarial services unit here at OHA, and that MEP consultant's name is Shane. Shane reviews the MEP reports that come into the ASU team, so therefore we wanted to have that consistency across the MEP work, and so Shane will also review any MEP utilization TQS projects as well. The MEP TQS projects will be scored according to the TQS scoring methodology, that 0 to 3, around detailed feasibility and relevancy. So that does not change as you know, to align across TQS, but we just wanted to make sure you knew that the individual themselves will be consistent across MEP. The other thing related to transformation quality strategy, or somewhat related, is a question came up at one of the office hours related to TQS, and it also came up during your compliance monitoring review training with HSAG, Health Services Advisory Group. In your, it was a training that HSAG was doing around your upcoming compliance monitoring review, site visits, and basically your desk audit. The external quality review that's going to be happening around that is around your QAPI. The question came up during that webinar. It also came up during TQS office hours. The response to that question, sometimes it's almost like a two-parter question, slightly different flavor of each question came into both of those settings. We responded in one email that went out last week. It went out to the CCO contract administrators and the CCO TQS leads just to make sure we had the breadth of who in a CCO needs to have that information, because it really relates to your compliance reviews that are happening with your external quality reviews coming up. And then of note, just kind of another reminder, just 2022 integration statewide PIP. So this is the integration behavioral health access PIP. The validation will be submitted on July 31st with your quarterly progress reports on the other individual PIPs. So just a reminder of that date. We are talking today about the SUD design phase statewide PIP. So I didn't want to get the integration statewide PIP mixed up with the design phase of the SUD PIP. So that's just a reminder for y'all. Any questions from the reminders and updates before I move on in today's session? Or any other questions not related to SUD statewide PIP or Exhibit I? Okie dokie. Let's go ahead and go to the next slide. So today we're going to talk about the SUD waiver and specifically the PIP development design. And we're going to talk about the Exhibit I complaints and grievances and NOBD. So I'll take the first hour in which we talk about SUD waiver PIP design, and then Carrie and John will take the second half of the session and talk about Exhibit I. Next slide, please. Sarah, would you mind going on camera? I would like to, before we go too much into the waiver reminder, I'd like to introduce you to Sarah Adelhart. Sarah, we want to give a shout out, wave hi.
Hi.
Sarah is new to OHA, so you're what, now a month at least?
Coming up on 2, yeah.
Oh, look at that. So, you know, we almost can call her not a newbie anymore. Sarah is within our behavioral health team. She's specifically within the SUD waiver team. And then she's going to be working with me on the SUD PIP design as well. So she's going to be kind of like project managing it, but she's also learning the ropes around the SUD waiver itself. So she'll be the SME, the subject matter expert for the SUD waiver, as well as kind of overseeing and helping me shepherd and move forward the PIP design development. We also might, I don't know if Dana Peterson's on or not. Dana, if you're on, you can, she's not on this one. Dana came and presented in the fall around the SUD waiver itself. Dana Peterson is transitioning that subject matter expertness and, you know, just downloading her brain into Sarah around the SUD waiver, but we also have Dana as a resource as well. I am just giving a quick overview of the SUD waiver, mainly because, again, Dana went into depth in this, but it helps give us the context of what we're doing, which is, you know, designing a PIP. So the SUD waiver, again, just as a reminder, it's effective April 8th through March 31st, 2026. It is an 1115 waiver, but it's specific around SUD that we approved with CMS last year. It expands our authority. I'm going to move on. Next slide. Go straight into, I believe, the goals. This specifically talks about the expanding. Something's called a state plan amendment. When you're on a Medicaid program, you have a state plan. It talks about how you are going to basically render services in the Medicaid program. These new services and supports are basically outline brief intervention, targeted case management, community integration, skilled restoration, reimbursement rate increases. So those are some of the broad categories that were put in the updating of our state plan amendment to address the waiver. Next slide. New services and supports under the SPA in the waiver. Expand the continuum of care for people with substance use disorders. Improve access to care for substance use disorders, including outreach, initiation, treatment, and recovery. A question came up in our email about, like, what does outreach mean? And does outreach mean, you know, potentially covering outreach for those that maybe aren't necessarily in that medical model of billing? The answer is not yet. We haven't figured that out, but it is inclusive of additional outreach efforts, but it still has to follow under some type of connection to a Medicaid medical biller. So in case anyone's wondering, there's the answer to that. Reduce use of emergency departments and inpatient hospital settings for treatments. Reduce readmissions to the same or higher level of care when the readmission is preventable or medically appropriate. Increase rates of identification, initiation, and engagement in treatment for substance use disorders. And then the last one, and not final, or not, not least important, but include housing and employment services in the treatment care plan. And that is one that I've actually had referenced recently. Next slide. The goals. So goals of implementing all new activities by January 2023. Doesn't mean we have to have met, just means we need to have started. So they align to all those things that we previously said. Include housing supports and treatment planning, increase rates. One of the things that we are going to be talking about here is the SUD statewide PIP is supposed to reach one of these goals. What I have started is a conversation about how we'll get to designing a PIP towards one of these goals. So we'll talk about that here in a minute, but we will start with a poll at some point. So just if you are not connected to a computer, then I'm not sure if you can do a poll over the phone, so I'm sorry about that. But if you are connected to a computer, know that you will be doing a poll here in the near future. Next slide. Here's kind of our timeline. So if you have been on the statewide PIP team before development, then you kind of know how we've done this. When we were in person, we do a lot of whiteboarding and a lot of talking in the afternoon, and then we take it back to the following month, and we take it in the morning and talk to medical directors and behavioral health directors, and we go back in the afternoon, and we did this iterative process. Last year, in the virtual world of COVID, we designed the behavioral health access in a series of meetings, internal and external. So we're going to follow very similarly. So how we did the integration PIP last year in the virtual manner at this point. So last year, again, May 2021, we informed CCOs that this SUD waiver was approved, and there's this concept of a statewide PIP in it. March 2022, so we are doing an overview of the SUD PIP design, and we'll kind of do some kind of brainstorming today. Obviously, we're not in a room, so we are going to get creative in how we do kind of brainstorming. In April, we'll hopefully get into topic selection and topic study question and population. May, we'll start talking goal, performance indicator. June, we'll start talking about measure viability. And what we again mean with that indicator measure viability, we have to make sure we select a measure that one can be measured, two, that can be measured across all CCOs, three, that has enough population across all CCOs that also warrants that all CCOs can, have enough population to conduct a PIP. So in the past, some of you might remember our first statewide PIP, some CCOs had less than single digits or less than double digits, and that doesn't necessarily work when another CCO has triple digit populations to work with. So we try and find a balance between the different regions of Oregon to make sure we have enough work for all CCOs to develop regional community-based interventions. What we'll still try and do is still develop a summary document for CCOs of all this work that happens between March and July. And then that summary document goes into, you'll get it sometime in August, and by September 1, you are submitting your EQ external quality review validation form to HSIG for the design phase of the SUD PIP. So any questions on timeline before we get to the fun stuff? It's pretty much exactly like last year. Next slide. Okay, So since I'm not on vaccine work, but I am on some other work, hopefully I'll have some smaller, greater capacity than last year. So we're going to do the second Monday of the month, these meetings, QHOC, QPI sessions to engage with CCOs and stakeholders. These are, again, operating as public meetings, so the public are invited to this meeting. We will kick off with fourth Monday of the month, second CCO meeting check-ins. Those have not yet been scheduled. Sarah, who you saw on screen earlier, will start to schedule those fourth Monday. Well, it's for it might not be the Monday, fourth week of the month. It may not be Monday. Fourth week of the month will be the second check-in. So what happens is, again, on the first and third, I'm checking in with internal staff. On the second and fourth, I'm checking in with CCOs, and we're doing that iterative process back and forth on whatever stage we're at in the development. CCOs need to send Sarah, and I put her email here, an email with the names of the staff that you want on the fourth week of the month regular CCO, SUD, statewide PIP development meetings. So then she can invite you. I will also be talking to our tribal liaisons. I will also be going to the Medicaid Advisory Committee. We've already connected Sarah and our behavioral health chair, Jeremy Kohler. We'll be talking about ensuring whatever discussed here at QPI session and how that connects over with the CCO behavioral health directors meeting or vice versa. Behavioral health directors at CCOs are more than welcome here as well, but want to make sure we have that conduit of information. I will also talk to the Health Equity Committee out of the Oregon Health Policy Board. So those are some of the engagement pieces. One of the other engagement pieces for external stakeholders that I'll be doing is writing some emails. I've already checked in with some internal staff in which they'll be checking in with some of our external listservs in which they'll be inviting them to these QHOC meetings, etc. Next slide. Okay. Let's go back a slide before we get into the poll. Okay, so that was just lightning fast. Some of it was just a reiteration of what Dana Peterson presented on before. Here's what the SUD waiver is, and here's the goals of the SUD waiver, and just reiterating the timeline that we've kind of followed before in designing a statewide PIP. I should express that most likely, again, because it's a statewide PIP, CCOs individually develop their interventions in their community. We will have one indicator. Agency most likely will be producing said indicator. It depends on what we come up with, honestly. So that may or may not be true. We'll have to see. You will have it ER validated through HSAG. It will be due September 1. And we will have external stakeholder input in addition to QHOC through what is expressed on this slide, and potentially other members will come to these QHOC meetings if they so desire. That's pretty much the quick snapshot. Any questions before we get into the polling and kind of really honestly just the didactic part of the conversation of where do we go? Okay, then what I'm going to ask is for y'all to turn cameras on too at some point, but we're going to first start with the poll, and I'm going to start with a very, very broad, and I know very hard, very difficult question. And there is no wrong answer. So go ahead and go to this polling question. But we got to start somewhere, so might as well. Go ahead and go to the next slide as well. The poll is, for my community, the SUD waiver goal that I want the statewide PIP to focus on. If you could just pick one, where do y'all think? It's interesting where internal went, so I just want to see where those that are on the CCO or whoever's on this call, where they think they want to go. like you almost don't want people to see the results because you should just vote blindly. Do we only have 26? No. I was gonna say we have 50 people on. Some people by phone. So let me see if we can wait for a little bit longer while people are thinking. I'm gonna try and get us up to the 60% zone. Oh, we just made it. I'll give it another 10 seconds on the poll. So if you hadn't voted, please put in your vote. Again, no wrong answer. I'm not going to hold you to this. It's just kind of a ballpark thought for the moment. It can change. It might change even in this meeting. Okay. And I'm going to close the poll. And then I'm going to share. I think I shared the results. Hopefully that worked. Okay, let's see. What do we got? It worked. Thank you, David. Thanks for giving me the confirmation. I like that. And thanks, Graham, for turning on your camera. I like to see faces. It's like we're in the room, but not really. Hi, David, too. Nice to see you. Okay, we've got 38% improve access to care for substance use disorders, including outreach, initiation, treatment, and recovery. Behind that, increased rates of identification, initiation, and engagement and treatment. So you guys kind of like got this treatment kind of vibe going on. And then I'll just say it's a tie amongst the others. Okay, let me see. Okay, what we're going to do next is I'm going to just, again, because we're not in a room, so it's kind of harder in a virtual world. We're going to do what's called our waterfall technique. I'm not sure if has anyone, let's go ahead and go to the next slide. Has anyone seen or used the waterfall brainstorm technique? You can just raise your little or clap your little Zoom icon. And can you go to click again, Jennifer? Oh, let's go back. Where did my pretty picture of the waterfall go? Okay, never mind. It went away. I had a pretty picture of the waterfall. Ignore that now. Okay, so I'm going to walk you all through what's called a waterfall technique. This is a brainstorm technique in a virtual world. So what it is, let's go ahead and go to the next slide. I'm going to walk you through some instructions. We're going to go through a couple key questions. This is just a get the brain thinking, get some thoughts on paper basically, or in the room, and get some thoughts on a whiteboard. And then there will just be kind of the open discussion, because this isn't just about Lisa talking. So in the waterfall instructions, what will happen is questions will be posed on the next few slides. After each question, the group will review and pause to reflect for about 90 seconds. Each individual will type their response to the question in the chat, but you do not select enter. So you type whatever your thoughts are to whatever my answer or my question is, or whatever's being questioned. There's no wrong answer, just gathering ideas. Again, we're not holding you accountable to anything. It's just, again, this is just purely what's your thoughts. When instructed to select enter, then you hit enter and everybody selects enter at the same time. And what you see is this cascading of everyone's answers, i.e. the waterfall. So we'll do that 3 times. So just normally when we were in person, you would do 3 different whiteboards and we'd sit there and brainstorm. So now we're going to use the waterfall technique together to answer 3 questions. And then we'll have an open dialogue about SUD topics in our community. So we'll give us a go and see how it goes. So the first question on the next slide. For my community, the greatest problem area for SUD is. So we're going to pause and let you think about that for 90 seconds-ish. And if I was really awesome, I would have come up with the Jeopardy music, but I didn't. And you can start to write your thoughts and responses in your chat, but do not hit enter until I let you know. Okay, you can all hit enter. Now we all take a moment, which is kind of the fun part of a waterfall, is you open your chat string and you can either pop out your chat string or look at it next to your pictures and just kind of scroll through it, and you just can see what everyone's thoughts are. And wow, they're still coming, which is great. Lack of housing, lack of initiation and engagement, 42 CFR Part 2 challenges. Yeah, we all agree there. Workforce, income disparity, increasing prevalence of overdose deaths, opioids, and the ripple effects. Stigma, access, engagement, workforce, timely access, SDOH, and all things related to that economy, physical housing, education, access, workforce, access to timely and local treatment options due to limited workforce. I feel this workforce theme again. Engagement. I'm going to want to speak on that engagement more. Is that engagement of providers or engagement of families, members? Engagement. Okay. So that was the waterfall technique. So hopefully, again, that works for you all. We're going to try this again, and then we're going to go into question 2, and then we'll go to question 3, and then we'll just kind of open it up for discussion as we're reflecting on what we see in the chat and just regular conversation. If you wouldn't mind advancing, Jennifer, question number 2. For my community, the CCO's most influence in SUD improvement is. And remember, please don't hit enter until I let you know. Krista, I see your hand up.
Yeah, Lisa, I think I know what the question is asking, but then I second guessed myself and I just wanted to clarify, is this within my CCO, within my own CCO? Or,
so basically, like,
okay.
you know, sometimes I hear CCOs like, well, we're not the only influencer in workforce, basically, right? I've heard that. So that's just one example. So where does a CCO think they are the most influential in assisting with SUD? So that's
okay. Thank you so much.
No problem. And we are close to, I think let me see if my timer. So I'm going to give it just a few more seconds just for that clarification. And thanks for asking, Krista. And then I'll give it and you all can hit enter. Oh, wow, that came in really fast. Funding for workforce, oversight, central collaboration between various treatment facilities with different EHRs, method, process, standardization, improved care coordination, case management, access to continuum of care services, ability to tell community-wide stories around SUD, collaboration with community partners, financial support of workforce development projects, education, measurement of new and renewed SUD diagnosis and initiation, engagement, and treatment, increase access to SUD and system navigation tools, workforce support. Great, thank you. This will definitely help as we continue to go on. Okay, and let's go to question number 3. Same MO, same. For my community, if I could wish all CCOs to work together on SUD, it would be on. So now I'm going to go ahead and give some context here. We all did a high dose opioid project, like what, 2017-ish? And we all, I mean, it was a pretty much consensus based right at the top of, hey, we're going to do this kind of line of work. And when this SUD PIP came to be, sometimes some people said, hey, Lisa, we're going to go do this. We're just going to do high dose opioids again. I've heard that, and then I've also heard no. So what I'm trying to gauge is also where you all are thinking, if you could have your wish list, do we go back in that space or do we not? And this is, again, no wrong answer, but I'm trying to figure out what people's interests are. And within that space, it has to be not just quality folks, has to be behavioral health folks, has to be medical, has to be also the members we serve. So I'll be reaching out to the Medicaid Advisory Committee as well as others. But I just kind of wanted to find from the CCO perspective what your thoughts were, at least those that were on this call. So any additional context or questions before I let you count your 90 seconds, since Krista had a good question the last time.
The question states, oh, sorry, I didn't raise my hand, my bad.
Oh, go ahead, David.
The question says all CCOs, but then my community. How does this overlap for communities that are only served by a single CCO?
I mean, like, basically, if you could pick one topic, what would it be? So,
gotcha. Roger that.
So
just making sure I understand the overlap.
Yeah. So in the past, it'd be like, well, I'm just going to pick on, David right now, since you're on camera. David, you wanted to, do MAT work, and Graham wants to do just prescribing work. David wants to go do workforce work. Graham wants to go do, closed loop referrals and coordination work. Pick one. Put what you think, if you could get your fellow CCOs to be on a topic with you, put it out there. Just put it out there. Other than, going to Disneyland. It has to relate to SUD. And not pie, because we already talked about pie this morning. So I'll give you your 90 seconds. Go ahead and go. And yes, I'm going to hold you, Graham, to it for whatever topic you put forth. No. It's just a brainstorm. If I could get all the CCOs to agree with me to do this. This would be awesome. That'd be fun if we all could work in this one space together. Try and remember not to hit enter. It's only because we don't want to, you know, get others to get with my idea before everyone thinks what my idea is. Okay, go ahead and hit enter. Looks like we got a few more on camera. Thank you for being brave, everyone. It's great to see faces. Improve access, MAT in primary care. Closed loop referral. Oh. Cat, really? Solving operational barriers for 42 CFR. I'm just gonna put that out there. I think that's everyone's wish list, and I've gone to CMS and sat with some lawyers, and it wasn't fun, and they were pretty honest. It ain't happening. But hey, we can ask again. That was, you know, a few years ago, but yeah, I hear you. Yeah, 42 CFR workforce. Creating a real-time system notifying CCOs and or providers when a member patient has a new SUD diagnosis. Interesting. Workforce. Focus on AT metric, timely identification of SUD treatment. Okay. Increasing the number of duly certified practitioners. Next slide, please. Just reading through the comments, which is great to see everyone's. Okay. Thank you for that kind of starting of getting the brain thinking in this space. Hopefully that got some ideas going, and it's always good to see what where you all are at. Now is the time just to kind of an open dialogue. We've got about 15-20 minutes of just what are people's thoughts of, if you look at the SUD goals, and I've already started to collect some data. So here's the other thing. If you have data sources that we should be looking at, because again, QI said, look at our data, see where our gaps are, but we also know sometimes in a quantitative fashion, sometimes the data doesn't tell us where all of our gaps are. That's another space that Oregon isn't in, is sometimes the data that we have doesn't tell us the whole story. So that's where we're supplementing that with qualitative, which is the member voice, the community voice. So if you have any specific data reports you want us to look at, then please let us know. But we are collecting some of those from OHA Analytics as well. But from your community points of view and from your data analysis and your providers and what you're hearing from members, where and what are your positions on SUD, and where? And I'm sure Kat has an opinion. And please don't start with 42 CFR, please, because I've already been there. But I'll go ahead and open it to the floor.
I'll start, but it's on a banned topic. The final rule for 42 CFR opened up the availability for non-specific and multi-party consent forms. Is that a space that we can explore to potentially work in some of these identification and referral pieces that is challenging what it looks like everybody?
You want to repeat that again, David, so I can take the proper notes, so I can ask all the proper lawyers?
For sure. So the final rule for 42 CFR Part 2 added the ability. It used to be we had to name specific individuals at specific facilities, but now you can reference a facility in general, and the rule opens up the availability for multi-party consent forms. By using some kind of a multi-party consent system, you may be able to name multiple treatment or care or case coordination parties as part of your intake that could help open up that referral space by having the ROI be a little bit more flexible. We're brainstorming that concept, but it's a challenging thing to implement, and just thinking about what the larger group might explore in that space.
And again, this is kind of open discussion, so people can just go off mute or raise their hands, react to David's statements, say, yeah, great idea, or you're figuring that out, or no.
This is Deanne with YCCO. And I think that is an important area to look at, given that navigating SUD and making sure that all the right consents are in place can be a significant barrier. So to the extent that we can improve the efficiency of those releases and ability to coordinate with a broader variety of individuals without requiring members to sign, 101 different pieces of paper, I think is going to be important. As we think about doing the SUD work, it's one thing to do the individual therapies within a single agency setting, but folks come with complex needs, and we need to be able to be exceptionally efficient with navigating the systems that will provide that wraparound support.
Thanks, Dan. Other people's thoughts?
Lisa, this is Graham. I resonate with what David is saying. If and I get like why it's kind of humorous to be like, let's not touch on 42 CFR, but there's a reason it starts every single time, and that's because unlike virtually every other quality improvement thing in healthcare, we can't effectively share information about this work to coordinate care. So that's probably why it keeps coming back around and around. I mean, obviously that's why it is, but it really ties our hands with one of the best tools that we have to actually do things better. I think the issue with something like a broader universal consent is that it ultimately lands on CCO or covered entities risk tolerance for knowing that we're actively tracking every single consent, whether it's broad or not, in like an open and closed fashion. And it's always felt like technology can maybe help with that. But I feel like we've also always been just waiting for the rule to become slightly more lenient, because it's always like one, the next sand dune over, like just one more, like it's going to become sensible. It's basically going to be like HIPAA, and then that's totally pulled back every year or so. So I'm mostly filling in space here to respond to David. That would be my number one fix, would be something around information sharing, so we could treat this in a way that's more similar to how we do quality improvement in virtually every other domain. And I don't have a good solution.
What CMS told us a few years ago, well, it's now been more than a few years ago, so probably 4 years ago, was they were not, and David, when you're saying 42, what time period was this?
The final rule update was the August 2020 rules update.
So it's from the 2018 mega update?
I believe so.
Yeah, so they came out. So the lawyers basically said they would come up with some clarifications, but that would basically be upon every state's attorney general to determine their level of risk with the existing guidance, i.e. the rule that was out there. Because I was sitting with Alabama, myself, maybe some other Midwest state, Indiana or something, because we were all asking the same question. Is the feds going to lighten it? Are you going to provide the guidance? Are you? And the answer was no. This is it. This is as light as it's coming. And most likely what came out in 2020 is it. We can go ask again, but they were pretty much, and this was the author of the rule at this particular meeting, which is why I was not, it's not funny. It was really sad. We were all like, well, great. If you're the author of the rule, then I don't think we can go any further of asking somebody since you are the person who's being charged with updating the rule. If in fact this is a space that, I mean, first off, I'm from a QI perspective, you all are probably thinking, some of us are probably thinking, how would you measure that? So if you think about like, thank you, David. If you're thinking about, you know, improved consent and release around 42 CFR amongst members, right? Then it's like how are we going to measure this? Just putting that out there. Because I'm pretty sure HSAG, who's probably on the line, is going, Lisa, how are you going to measure that one? Doesn't mean that we're there yet, but I understand that it's a barrier for a whole host of other things, coordination, treatment, all that stuff. So, because there'd be also a question, and Sarah, I don't know if we have any other behavioral health folks on this call from inside the agency. Do we, Sarah? Do you know?
I don't believe so, not today.
Okay, so this is why we have the iterative process. I go back to OHA and say, hey, here's what the CCOs are asking. What's your thoughts? Is this a space that the state wants to even go to? Because this is this space is also, if it's a unified approach, i.e. statewide approach, and there's the fundamental question of, does the state even want to go into this space, which is like attorney general people, definitely not Lisa Bowie, quality improvement at OHA alone, and definitely not even Pat Allen or Steve Allen. This is like full lawyer stuff. So I would have to talk to lawyers, which is totally fine, but I have to find out if that's even a space we're going into, right? But I will try and take what you all are saying. And Lisa, did we then seek a unified report from the state attorney? No, we did not. I did not go to the state attorney general, Graham, after we heard from CMS. I did report back from that CMS meeting that basically they said no go. Like they said, nothing's happening. The feds are not putting out any further guidance after that. Dr. Katrina Hedberg was still here in 2018. This is when we're still working in our opioid work. So Katrina and myself let all of leadership know the federal position at 42 CFR, straight from the lawyer's math. And at that time, it wasn't, you know, it wasn't saying, hey, let's go do this. So I will take whatever feedback I get from y'all and take it up the chain like I usually do. But we can again, we can flesh it out. We can talk some more, and you can give me all the reasons why this is a problem, and that will give me even more conversations. And no, I'm probably not going straight to the state attorney general, because that's not my style. I'll probably go somewhere below that. But yes, that's basically who you have to go to. What are people's thoughts on that matter? Does and how does the 42 CFR limitations and confidentiality and all that other stuff impact your ability to coordinate and deliver care for this member population? I'm assuming you all are going to give me a thumbs up that it's prohibitive. Well, at least I remember it when I was in the practice, but that was 7 years ago.
the time it takes to hunt down those signatures and get, permission to share information makes it extremely difficult to hit, even from a metrics perspective, not even talking about the clinicality of it, but even just to try to hit the metrics, that 14-day first hit window is extremely difficult to navigate with the level of follow-up and re-ask and reshare and then transmit. It slows everything down to the point where we know that the difference is days. A single day of time elapsed is an opportunity for an affected member to relapse or continue in dangerous behavior. The sooner that we can get this information, get it shared with the right people, get those follow-ups scheduled, it's purely the time.
So time is an administrative burden, but time is also a negative health outcome burden, because when the individuals need the care, they need the care in this particular condition. Is that a fair assumption of implicitly saying what you said, David?
Yes.
And what Dan said and what Chanel just said yes to. Okay. What are other thoughts? So I see YCCO, I see Health Share, I see Cascade Health Alliance. I mean, from a CCO perspective, is this generally speaking fairly consistent of a statewide issue?
Lisa, I feel like you're going to hear yes from folks, but I don't know that that means that that's the focus of the PIP, right? I feel like David was kind of clear, like, let me just bring up a thing early on, sort of, circling back to the thing that's always there. I don't know how getting those consents is measurable. I don't know how information flow is measurable to the level of a PIP. It's going to impact all of the starting points in terms of any performance on a thing. It's going to impact all of the ability to actually improve in the way that we want to. So it's just perpetually there. And I would hope that OHA is constantly advocating, as much as possible to ease the burden of 42 CFR, regardless of a PIP, but just because it's constantly there. And it's so counter to all the rest of the conversations we have around health information exchange and EMR interoperability, and virtually everything else. I mean, it's such a self-evident issue, but probably not a PIP in and of itself. Like, how many visits did Lisa have to the state attorney general's office this month? And can we get you like Gatorade and stuff to get you there another time? That's not a good PIP measure.
I can just see Don. Don's on this call from HSAG. He's like, that is not a measure. How many, let's just take Lisa's calendar and look for state attorney general and how many times they went there. Okay, so I hear you. It also is a contributing factor to any of the other PIP topics we actually do move forward with, because it is a significant barrier to actually doing care and coordination. Just putting that out there. Kat, are you going to come up with a different idea? I know you are. What is it? And don't say high dose opioids.
No. So, I mean, there are a lot of things that we're working on right now that would be really helpful to have more alignment. So for example, we're trying to really expand naloxone availability in bulk and not prescribed, and so having alignment across the state as to best ways of doing that, making sure that HRS is totally supportive of that, like all of that. So that would be an area that would be of interest. SUD peers, we'd love to have a whole bunch more SUD peers that are trained and registered with the THW Commission. So that would be a super helpful place. Contingency management. There was just a federal judge state, whatever they're called, decision that basically allows contingency management for meth use disorder. So really kind of creating easy pathways to make that work. So I feel like there's a lot of work that we're doing, and where it'd be really nice if there was some alignment across the state.
For those that were talking about the workforce needs, and workforce did not necessarily work out for the integration PIP, and I'm not sure, because again, the measure factor is an issue. But since that time, we've also know that a lot of funds have come from legislation and have been infused into the system, and there's different reporting structures. So I'll again circle back to our workforce team to find out what's out there in the land of measurement around workforce. But for those that brought workforce up, what were your thoughts in that space? workforce
This is
training?
Erin from, this is Erin from All Care Health, and I would turn my camera on, but I can't. I'm sorry. One of our providers has created a pilot project where they've actually developed a curriculum that's been accepted by MACBO, and they are training CADCs and then providing the internship hours and all of that within the actual agency. And so I don't know if we can measure, additional numbers of individuals added to the workforce, number of people credentialed, or programs like that.
Okay, thank you. It would be, again, I will check to see what our current workforce numbers are. And part of it also is where some of our DSN delivery system network reporting baseline numbers were or aren't. And that was a factor a year ago, but we can see where it's at this year. So they're just conversations. What are other people's thoughts on the topic areas of just alignment to things you're either doing in your space, or again, the problem areas that you want to dive deeper? When people are bringing up engagement, again, is that engagement of the members, engagement of staff, the workforce? I just saw engagement a couple of times. What was that about?
This is Jeremy with Pacific Source. I put engagement in treatment, so more associated with initiation, engagement, treatment, QIM.
Okay. Thank you. Are you all thinking about it from the specific of the IET measure and the alcohol and other drugs, or specifically within other populations? See lots of workforce support, assistant care coordination. Can I see a show of hands about the incentivizing X waivers? Providers, how have you all been doing since the last waiver ended, and that there was a lot of work going on in that space already? Does that need continued focus, or no? I just, because someone brought it up in the chat string. Okay, I'm just reading the chat string. Any other last thoughts so I don't want to move on to the next topic before I remind everybody to send Sarah an email, because we're going to be talking, I'm honestly meeting with the internal group, and then I'll be meeting with you guys again. So I'll be saying, hey, here's what happened at QHOC. Here's their thoughts. And in that group is a host across OHA. So there's innovator agent, there's behavioral health, public health, a whole lot of behavioral health, SUD, analytics teams, myself, and then I let them know what happened here. And then we talk again, looking at data, looking at feedback from community, and then we say, here's where we're leaning for topic areas, and we come back to you all. So whoever's going to be in that 4th week of the month, make sure you let Sarah know. Otherwise, you're only going to be engaged at the QHOC, this meeting here. So you might miss a meeting if you don't tell us that you weren't invited. And then Graham, it looks like you have your hand raised. Oh, Sarah's, thank you to those who already sent names. So thank you to doing that. Graham, what's your question?
So making sure, okay, I'm on mute. So Lisa, can you just refresh my memory, like conceptually in signing up for this PIP that's statewide, how much is OHA sort of planning on also leaning into this space with us? So I'm thinking about like cat raised like peers and substance use. We know from our THW plan that there's issues from the community provider, CCO, all the way up to state level, right? In terms of everything from credentialing to training to all the way, DSN requirements, all the way down to how do you pay and what do staffing models look like. When and if we sign up for this, the PIP, is the presumption that OHA would also be like one of those sort of ecosystem participants in the work to start, like if we had as a broad or ambitious goal across all CCOs that we want 3 times more peers in the next 5 years in all of our CCOs, and there are barriers, not in a finger pointing way, but just administrative barriers that exist at the state level. Could we assume that the state would then lean in the same way that we're being asked to lean in? Or do we need to be selective in those areas to make sure it aligns with what OHA is already planning on doing?
The answer is, well, I would probably say it's somewhere in the middle, because some of the work we already know that's underway, which is currently from certain current legislative priorities and other strategic plans. I know I'm still getting community input to inform strategies. So the answer is, we design a PIP, and in fact, I still have work yet to do on the integration PIP to figure out who in the behavioral health world I need to be connecting with to give you all that kind of OHA connected resource of when you identify the barriers of who should be helping break down those barriers within the state. The same should happen from the SUD side, whatever topic it is, whether it's workforce. Now, just like when we collaboratively come up with this topic, we can't magically make workforce appear, just like you can't magically make workforce appear. But there is that conversation to be had amongst what is the state working on, aligning some of those levers of the legislative investments in workforce, or the legislative investment in creating, more beds in the behavioral health world, like we talked about this morning. So those are the known ones. The other ones that are not known are the ones that we're still waiting, that we're still hearing from community on, honestly. So that's hard to say.
Thanks.
But in a perfect world, yes, because I am connecting with, but have not yet, but will. So for SUD, you also have Sarah and Dana, who are well connected into the SUD teams. And it's a little bit more specific in SUD than broad behavioral health or broad integration. So in SUD, it actually might be, I want to say easier, but it might look a little different, because kind of like an opioid world, we knew exactly who across the agency to call. Like it was very easy to pluck different roles and say, okay, in the HERC, we're going to go do this. In public health, we're going to go do this. In communications, we're going to go do this. Data, do this, because it was a very specific topic. SUD is a little bit more specific than behavioral health integration access, right? So it might look a little bit more like our opioid work, wherever we land with SUD is my guess, just because the staff are a little bit more aligned. Any other questions about? Thank you, David. And there's Sarah's email. Yes, it's also on the website if you want. QHOC website has a contacts list for anybody's contact information for any QHOC meeting. So by all means, look at the contact list as well. And I will transition to Exhibit I. This is, again, the first of many conversations that we get to have between now and June, into June, hopefully, that will be rounding out the SUD topic area. I will most likely, at some point, you all know we usually get to a vote. We're not even anywhere near a vote, so don't hold anything that you said. I'm not holding y'all accountable to it. David, I'm not going to make you come to the state attorney general's office with me. Don't worry about that. But I will use your chat string and messaging. So if you want to continue to add the chat, please do so. We will, again, take this back to the internal meeting. Sarah's going to help clean all that up. And then we will start to provide resources of information to you all from what we're hearing from the community, like a community input report that we have. Here's what, if I could, you know, make this happen easier in my community, this is what I want, right? And if it relates to SUD, then I'm going to have that lifted out and, you know, really honestly give it to you and give it to me so that we can use that as information of here's what the community need is. So stay tuned for resources coming your way and or more polling. So thanks for the conversation, and I'll turn it over to Carrie and John, I believe.
Yep. Hello, good afternoon. So my name is Carrie Williamson. I am a quality assurance and compliance specialist with the quality assurance and contract oversight team in CCO operations and HSD. I'm joined today by my colleague, John Levere. I'll let him introduce himself.
Hi, everyone. I'm John Levere. I am the quality data analyst on the quality improvement and compliance team. And yeah, back to you, Carrie.
So we're here this afternoon to provide an update. We came and presented, I looked back, I couldn't believe it's been that long. We came in August to talk a bit about some work we were embarking on at that time around building out a dashboard using the quarterly grievance and appeal system information that the plans report as a part of Exhibit I. So providing a bit of an update there, and then hoping to solicit some feedback from this group since we did bring this back in August. Wish we had I wish we could say we were a little further along in this process than we are, but we had some kind of big lessons come up along the way. And we have some thoughts and recommendations based on those lessons that we want to run by this group. And also want to say that we will also be bringing this to the contracts and compliance work group as well for some additional feedback and thinking. The reason, we came and presented in August again on the dashboard work. And then, we fully recognize that the grievance and appeal, that Exhibit I information is used throughout the plans for a lot of different, quality activities. So we wanted to make sure that our thinking around the path forward towards this dashboard and some potential changes that we're thinking through around the template won't be creating any waves for the plans in terms of how they use the data, how you store the data and use it on the quality side. But again, this will not be the only place we have this conversation. So with that, if we could tab forward in the slide deck, and a lot of this, you all know the current state. So, you submit your Exhibit I quarterly report on a quarterly basis. It's got that grievance information, the NOABD information, the appeal system information. We report a subsection of that to CMS and we do some ad hoc analysis on that. But our intent is to move that information into a dashboard format so we can get a quick visual sense of the landscape of grievance and appeals around the state. So we also want to recognize that the current reporting tool was developed in collaboration with the plans. A lot of work went into that, into defining the categories for reporting and the build out of the tool itself. So again, before we start making changes to the tool, we want to check with the plans and make sure that the proposed changes we're thinking about aren't going to be too terribly disruptive. And if so, we want to hear about it so we can think and be planful around our timelines there. We can tab forward in the slides. So I will let John talk a little bit about the process we went through to build out our beta proof of concept dashboards and some of the lessons we learned there.
Yeah. So the process that we went through was taking about a year's worth of the quarterly submissions and cleaning the data and combining it into Power BI, or actually we used Excel, and the Power Query tool to compile and clean all the data for about, like I said, it looks like 2 years actually, 2 years and plus 1 quarter. And we during that whole process of combining and cleaning, we noticed several kind of like data quality issues that like were occurring multiple quarters, as well as one of the largest issue was the size of the individual file submissions. And so part of the cleaning process required us to essentially like copy and paste things from the template into a smaller file size. So that way we could more easily combine 2 years worth of submissions. And so, yeah, then once we went through the cleaning process and the combination process, we developed like basic charts like you see here, just kind of plotting the frequency of the different types of grievances, and we did it for appeals and NOABDs as well. And so kind of the lessons learned was mainly reducing the file size of the template. Currently, the template has several tabs that aren't necessary for the data analysis. Like there's tabs that have kind of like more instructional components to them. And so we are hoping to be able to kind of remove those instructional tabs and house them in more of like a instructions document. And so that way the instructions and the reporting would be 2 files. And then additionally, there are several things about the Excel template that make it a larger size. Like there are several macros. So it's a macro enabled spreadsheet, which means it has a lot of like coding going on in the background and a lot of security stuff going on. And I think for our purposes, it's not really necessary for the analysis. So we want to essentially streamline the reporting to where, and I'm sure you all are familiar with like reporting and like spreadsheets and overly complex processes around that. And so we're just hoping to simplify it, not really change like the data that is being reported, more so just the way that it's being submitted to, like I said, streamline the process that we can more easily combine and connect it to dashboarding tools.
Again, we just kind of wanted to put this out there for plans because we weren't really sure what the landscape looked like in terms of do plans have other formats that they're using to analyze their own grievance and appeal data, make sense of that, use that for their own operations initiatives, quality work. Or are folks relying on the reporting template as a primary means of storing and analyzing their grievance and appeal data? And you may not have an answer to that right now. We just, again, kind of want to put that question out there. This will not be the only space we ask that. But again, if making those kinds of streamlining changes to the template are going to be disruptive, we want to know about that to provide enough lead time before those types of changes are made. Of course, there's the 90-day timeline before we can, for releasing updated evaluation criteria and guidance. But if it's going to be a substantial disruption to plans, we can always kind of think about those timelines. And I see some questions in there around exported from the reporting template to a .csv for submission.
And yes, that is 100% the way that we are heading. And I'm glad that some of you are already familiar with CSVs and how much easier it is to share it. And like I said, the file size is much smaller and easier to work with. So yeah, CSV would be ideal, but there are other ways that we can accept the data. It doesn't have to be CSV. Just kind of, yeah, the plan is to develop like an updated template in Excel, and then like you can either use that Excel template, or you can just submit a CSV or a pipe delimited text file, whatever works for your systems.
So if we could tab forward. Right, so what we're mainly thinking about are these streamlining ways to streamline the reporting tool. Based on the conversation, it doesn't sound like there is a great deal of hesitancy around that. Again, this won't be the only place we have this conversation, and we'll be putting forward a list of more kind of solid recommendations around that streamlining process. Another thing that we wanted to talk about just very briefly at a very, very high level, because we're still working on the implementation and operationalization of this on the OHA side, is that House Bill 2517 requirement around prior authorization information and incorporating that into the Exhibit I reporting, which has also been updated in the contract. Of course, we've got the 90-day requirement around, updating the evaluation criteria and guidance documents. And again, still operationalizing this, but also if that is going to be a heavy system lift, thinking through that when we are, thinking about our timelines on the OHA side of things. So more information to come around that. Yeah, and then if we could tab forward, I think. Question and answer. Got a kid awakening time, so apologies if you can hear that in the background.
Yeah, so one of our concerns was whether plans were using the current grievance and appeal template as like the source of truth for their grievance and appeal data, and potentially like updating it and using it for other reporting criteria. And so we just wanted to make sure we get the plans as like input before we implement any kind of changes to the template.
This is Laura from also CCO. And we do use the Exhibit I as our source of truth for when we're doing any of our reporting. But we also have additional information built into our Exhibit I that we abstract out before submitting it to OHA. So like we are already incorporating like the real D data and stuff into our current internal Exhibit I that we strip out for OHA. We also use it, I also use it for, like, we have the parity audit that's going to be coming up. And so when we're pulling the data and the information that we're going to need to submit for the parity audit on denied authorizations, I first go to the Exhibit I, because almost all but 2 of the fields are already currently in the Exhibit I that we need for our parity audit. So that way it kind of aligns that, and OHA is getting the same data across all sectors when they're requesting appeals and grievance data from the plan.
Hi, this is Kristen Lassajohn from HealthShare. And I will say that for us, I think that, we end up aggregating the data from that OHA template from our different health system plan partners. So we can really feel your pain on the formatting and the, the deep macros and all of that. So something that is stripped down would be very welcome in that sense, because I think we would, it would just be having something more streamlined all around would help us, I would say, at multiple steps in the process, both our own aggregation, and then also we then take that data and put it into our own Tableau dashboards. And so, having a simpler format to do that would help us with some of our stored procedures. So I would say all in all, like anything that is more simple and straightforward and less formula, and maybe CSV or pipe delimited would be a welcome change. So yeah, I mean, obviously not without knowing what it is yet, hard to say exactly, but I think moving in that direction sounds like really positive.
Sounds like a lot of us are on the same page with that. And yeah, the formulas that are currently in the template, OHA is not really using that data internally for our CMS reports. And I don't know if the plans are using those formulas to keep track of anything, but I was kind of leaning towards just kind of removing the formulas, because really it's just a pretty simple, formula that's like, oh, if this field is greater, if this date is greater than this date, then put a Y or else put an N. It's kind of technical language, but are there any plans that you think the formulas are helpful for their processes?
This is Levi at Trillium. I would say we spend more time fighting those formulas and making sure everything is formatted correctly than we do using them. So I completely agree, like Kristen, with what you said. Just every word that you said totally aligns with what I'm thinking as well. So thank you.
Perfect.
And then I put in the chat our HST quality assurance email in case folks, aren't quite sure, they have some additional thoughts, after this session. Please feel free to reach out through the email and let us know. And again, we will come around to some other groups and have this conversation as well. Who likes formulas, Lisa? I'm sure they can be very helpful. But it sounds like there's growing consensus that we could move to a more streamlined reporting template without suffering ill effects on the plan side, and we would certainly appreciate that, because it would streamline our ability to load the information into the dashboard. It was a lot of time spent cleaning the data just to get to the proof of concept dashboards. So any way we can simplify that process would be wonderful. And I see IHN is agreeing that is a good direction to be moving in. Okay.
Yeah, and then there are also so there's essentially 3 tabs that we are currently using for our analysis, and it's just the logs. It's the grievance log, the appeal log, the NOAPD log. And then there's a few other tabs that are like outstanding, and we don't really typically use those. So like, I think we should just narrow it down to just those 3 tabs, and it could either be sent in, an Excel file with 3 tabs, or it can be sent as 3 CSVs or whichever. That's kind of the way that I'm envisioning this. I'm kind of getting more into the details because I get a sense from this group that people are interested in moving towards this direction. But yeah, if it's too technical, just we can like, this is not the final say. This is just kind of like an introduction, giving you a little bit of an idea of what we're planning. So more discussions to come.
Okay. Yeah, like I said, I wish we had a little more substantive update for you on the dashboard side of things, but that data cleaning was really a heavy lift, especially for the volume of information that's reported on a quarterly basis, and then multiply that out across a few years. We were very lucky to have an intern through OSU helping us with that project, although that was a limited resource. So again, lesson learned there around the importance of streamlining those reporting tools as much as possible. And then hopefully we'll be able to come back sooner rather than later and we demo some of the dashboards and, you know, connecting up real D information, and it will be wonderful when they're ready to go. Okay, and I see some other good feedback in the chat. Thank you so much. All right, John, anything else you'd like to add on this?
Yeah, well, I think like the final, so the current template to me kind of feels like it's like the instructions and then the actual template, the reports, and then also like the formulas and the macros are like kind of like the analysis, and it's all kind of pushed into this one giant spreadsheet that's overly complicated. And so I think just splitting those things, so we have like the instructions and the quarterly submissions and then the analysis as like very separate, because that way you can do them each more efficiently. So that's just kind of like the final thought for me.
Okay. Well, that's all we have this afternoon, unless there are any other thoughts, questions. And again, you know, if thoughts come or you want to take this back to your teams, the HSD quality assurance inbox is a great place to reach us. And we welcome any feedback or thoughts on this process. And then, you know, be on the lookout for more information from us around this. Hopefully, we're kind of thinking potentially for the Q2 report due in August, so updated guidance in May. That's kind of an ambitious timeline, but we'll of course be communicating those changes well in advance of any actual changes to the template.
Thank you, Carrie and John. It looks like, you know, some people are going to be very happy with removing some of these formulas. Sounds like they've been a little bit cumbersome and annoying, maybe a little bit, just for a few people. Okay, so we've got a bit of time. I'm going to go ahead and just go with a couple of future announcements, and then we'll just do items from the floor. I mentioned earlier in the morning session that the April Learning Collaborative will be on the initiation, engagement, and treatment for alcohol and other drugs measure. So I emailed the quality staff of CCOs two potential formats for that IET Learning Collaborative. If y'all wouldn't mind replying back if you had a particular format preference. We have some integrated practices that are willing to come to that Learning Collaborative. We do not have any non-integrated practices. So recognizing that not all communities might have an integrated behavioral health and physical health practice, if you are aware of or have any singular practices in your community that are doing IET well, or want to come to the table for this conversation, then please direct that to myself and I'll connect them with Laura. Right now, it's just integrated FQHCs that seem to be doing well in this space of IET. That's what we know. You might know differently in your community, so please direct them to us. The other Learning Collaborative that's going to be in June will be around childhood immunizations. So recognizing coming out of the pandemic, yes, everyone crossed their fingers, recognizing that a whole host of preventive health things have kind of taken a back burner to COVID. We thought that childhood immunizations would be a good topic to bring forward. So it looks like we've got our public health immunization team prepared for that one. And then potentially some future Learning Collaborative topics in the mix are that Family Connects program. We talked about it maybe November, December. It's a home visiting program, came out of legislation. It's Kate Wilcox from Public Health came and talked about it. We're thinking we might need to kind of dive a little bit deeper into that program now that it might be more regions have been brought on. So that could be another Learning Collaborative topic. And then obviously at some point, I'll come back to you all during an actual QHOC and say, what other topics are you wanting us to explore for learning collaboratives? And so those are what kind of what's in the hopper right now. Childhood immunizations for June, potentially family connects, home visiting, maternity child care. So that's what I have in the future. Obviously, you know, the QPI sessions, 1 hour will be dedicated to SUD PIP development. What are your other thoughts on and or needs that you want for these sessions, and or any other questions? We did do in the past the TQS learning where you all brought a TQS project. We've done a PIP learning where you brought one of your PIP topics. We'll probably plan for that as well. We did those usually in the fall, but after you kind of got your assessments back, so we probably won't do those in the spring, summer, but you let Laura Matola or myself know what topics you want. Or Laura maybe has a list already. Laura doesn't have a list. Laura's going to do a song and dance at the next, she's going to do interpretive dance at the next QPI session. That would be kind of scary. We have an hour. You have an hour. You have an hour. And we have an hour for SUD PIP, and you have an hour for Laura's interpretive dance, unless she otherwise comes up with another topic. I will work diligently hard on coming up with another topic. This is what happens when you're chair. No. Pie baking session. Chanel, you know, that would be awesome. Review of CCO quality performance in 2021 measurement year. Ooh, Tanvir, just bringing it right back to reality. Thank you, Tanvir.
Thank you.
We appreciate you, Tanvir. What other topics are people interested in? At one point, you guys did a kind of a work session on notice of action language together. We've talked about doing, we did have Real D come and we gave you guys an update. Not a lot of change there yet. So it's kind of too early to come back and give you an update there. They're working on some, you know, technical things. So I could have Workforce come and give you an update on just a whole host of Workforce things if that's of interest. Since Workforce seems to be a heavy theme that you always come up with an improvement and highlights of high scoring TQS projects. Yes, Kristen, and we tend to do that, but that usually is in the summer, fall after we actually score and you get your assessments back.
Oh, right. Yeah, I meant, sorry, I didn't mean like right away, but just sometime after the scoring comes out. I always love hearing about other people's projects.
Yeah, did you guys like doing that where you all brought your own, you know what I mean, and did a little breakout room talking about your own
Yeah,
work?
that was fun. I enjoyed that.
Okay. We'll plan to do that again. Do you guys want a Workforce update? You wanted a Real D update. I can't remember if you wanted a Workforce update. Oh, I know. And I should say, you're going to be talking about waiver quality, or the quality strategy. I presented on this, I don't even know when, sometime last year, that we're going to be updating the Medicaid quality strategy. So just like you all have a quality strategy, you have policies and procedures, you're going to be going through your QAPI compliance review with HSAG, and please, again, use those HSAG reference documents like, you know, they're the source, and CFR. But we have a Medicaid quality strategy that's attached to the 1115 waiver application. And as the 1115 waiver application goes through and gets continually negotiated with CMS, then we'll be updating the CMS 1115, we'll be updating the CMS Medicaid quality strategy for Oregon. And so I have brought that to your attention before, but I'll probably be bringing it to the afternoon session and the morning session. We'll be needing to, very similarly so to the PIP, get input from external stakeholders, you all as TCOs, external stakeholders like Medicaid Advisory Committee, tribes, all that list that I just said for SUD PIP. And that will help inform the goals and objectives that are outlined in the strategy. So you'll want to get familiar with the state quality strategy if you are not, because I will be coming back to you all asking for your substantive feedback. And if you don't provide feedback, then guess what? You get what we come up with. So I'll be taking it to the hospitals, I'll be taking it to the tribes. Like I said, I'll be taking it on a nice little road show across the state. Just because I like to have fun. So quality strategy will be in there right along the statewide PIP development. What else is there? We'll talk about the performance report. We'll talk about CQS projects. We'll talk about PIP projects. Anything else anyone can think of? If not, then it will be Laura with interpretive dance.
Thanks, Kat.
I think that'd be lovely. What SW PIP baseline data? SW.
Statewide.
Statewide. Which are you thinking integration? I think of Southwest Airlines. Sorry, it's like obviously I'm done, guys, for the day. Caleb, are you thinking the integration one? You're thinking integration. I will get you. Thank you, Caleb. In fact, I have that in my email box. I'm going to circulate that. I believe it's coming up, and we usually wait till the end of March for the first quarter claims leg closeout, or the claims leg period. I will find out. I think that's the email in my inbox. So I will resurface that email of them saying, hey, Lisa, we're waiting for March, right? And get that for y'all. Possibly tag in some MEP integration strategies into those TQS topics. There were enough questions throughout the process to warrant a more exhaustive exploration of that space. Okay. Would that be, I'm going to ask you a question about that, not just necessary, David. The people who own MEP in your CCO land, is it all you all now, like as in the quality staff, or is there much actuarial crossover of owning that bodies of work? Yes, Laura?
We do. Ours is a huge combination of our chief medical officer, our actuary, our care coordination, and our and quality all together.
Because I know that the ASU team, Actuarial Services Unit, holds MEP meetings, MEP meetings with MEP people. And I'm assuming those MEP people are the actuarial people of CCOs more than the quality folks. And it looks like a couple of you are saying it's kind of co-owned. Some are saying it's mostly QI. So it's a little bit of both. Do y'all think we should have a combined session, maybe here, a QPI session to talk about it? Because I think that would be great. I really think we should. Whoever those MEP people of ASU and the ASU people of OHA and the QI people of OHA and the QI people of CCOs all come to a QPI session. Okay. I think that'd be very beneficial. I think y'all, we're all on something. Good job, David. Thank you. I will bring that up because I have a MEP meeting to talk about internal coordination, and I can say external coordination is actually asking for that as well. And why don't we, once we figure out internal coordination, also talk about what we can do about a future QI or a QHOC QPI session meeting to talk about expectations and roles and what's going forward and what that looks like, et cetera, et cetera. Do that in this venue. Anything else? Otherwise, that gives us a few things. It may not be that we'll have that by April, but I'll figure something out and we'll talk to Laura. Otherwise, again, Kat, you'll see some form of interpretive dance by Laura. Otherwise, we'll work on some other of these topics and report out. Don't you love how I just nominate you, Laura?
That's fine. I just might be coming down with a cold that day.
I'll have a migraine. You guys are quite impressed I don't have a migraine today.
I am.
I know, isn't that great? You see a neurologist and look what happens. They give you, hopefully migraine prevention. So, okay. Well, Laura Matola is your trustee chair. So either you help her out and you give her topics, or you help her out and don't give her topics, and she will do interpretive dance. I will package up some of the SUD work. I will reach out to the MEP team. We already have a meeting scheduled, just whether that gets done in time for April's QHOC, I don't know. We already have some of those other things worked into the schedule, or the quote schedule related to MEP and the kind of metrics report, Tanvir, of when we bring those to QHOC, QPI. So I'll put those into kind of the schedule that we already have. And then I'll share that with you all so you can kind of see, like, here's when the report comes, or here's when we talk about it, and here's when the scoring comes on TQS, or here's when we talk about it. And then you'll see kind of where the quote holes are for QPI sessions and where we fill it with interpretive dance or other topics. So it's email Laura, email myself, and we can always fill it with, debating SUD PIP topics. I'm sure we could fill a whole host of conversations around workforce and 42 CFR problem solving. I mean, we could just do that. I'm not going to invite the Attorney General, so we'll see where we go. With that said, I'm going to give you all back some time, and you'll see some kind of follow-up email from me in the next few days once I get those files from Nathan from this morning's session. So thank you all.
Thank you, Lisa.